Great pleasure to welcome you all for this exciting discussions, which is named as Revisit ASCO GI 2025. To do the honors, it's a pleasure always to welcome Dr. Vamshi Krishna, Director and Head Medical Oncology and Hematology at the prestigious AIG Hospital, Hyderabad. So once again, very warm welcome and good evening to everyone. So Dr. Vamshi, the floor is yours to set the context for today to take the things forward, please.
Good evening, and thank you everyone for joining in. As we had a previous session on a deep dive of a particular conference with the idea that we would be discussing a few abstracts by specific moderators and faculty who are well versed in doing this. And in particular, we are discussing today GI cancer. So all the panelists, moderators, and speakers are people who are doing more of GI in their practice. I don't think in India we are completely site specific, but we are certainly doing more of these as compared to other cancers. So the idea is we will have a very in-depth discussion on each topic about how we are going to go ahead. So the first talk will be by Dr. T.P. Sahu, who really needs no introduction from Bhopal. He's a well-respected figure across all conferences. And his panelists will be Dr. Sumit Goel, who is a senior consultant at Rajiv Gandhi, Dr. Safalta, who is a consultant at Amrita Institute of Medical Sciences, Faridabad, and I'll be joining in this panel discussion as well. So, Dr. Sahu, over to you.
Yeah, thank you, Amsi. Thanks for the invite. I'll just share my slides and then and then I think we'll be good to go. Okay. Is it full screen? No. It's not full screen?
No, sir, it's
Also,
not.
it's not.
Okay, I'll just do the full screen thing and then we are good to go. Okay, so I think now it's a full screen.
Yes, sir.
Yeah. So thank you. Actually, this is my second GI deep dive which I'm doing, and it's a good concept, and I really appreciate. And actually, I at least learn a lot when I do prepare slides, and this keep me in tune with what is happening as advances. I have a lovely panel of Sumit, Safalta, and Vamsi who just introduced all of us, and let's go. And we will have three abstracts to go. And if time permits, I have taken the liberty without informing all the fourth abstract, which will be a little short one on HER2 positive. I'll see whether that abstract will make some sense. So I put the fourth abstract, I think, the URTC trial. Okay. So for things to go on, we will go to the first abstract. And the first thing is this is a very straightforward design, which we all know, the science trial, and this was for esophageal squamous cell carcinoma. This included those patients who were considered to be operable. So what we really did in the cross trial. So Sumit, if such a patient comes down to you, mid esophagus, or let's say a lower, maybe a squamous cell carcinoma, what would be your go-to protocol as such today?
As of today, we are still practicing the cross protocol, sir.
Okay. So any issues on this design of the study? Do you have anything to add to this, or anything which you have a concern with the design of the study?
So there, one is the standard arm, which we are following everyone, but the drug that they have used is nab-paclitaxel. So as a radiosensitizer, it is equivalent, or there are differences we do not know. Okay. Second thing is, one is the simple chemotherapy arm, which we don't feel is the standard, but they have tried to add IO drug to it. So maybe that is there, and the arm B is a combination of the both.
Okay, so basically, what I get from you is you have a concern for the arm A, which is which you don't practice as such as a neoadjuvant intent. Am I right, Sumit, on that part of it?
Yes.
And the second part is you are not okay with the nab-paclitaxel, not sure of the radiosensitivity, what nab-paclitaxel can do in contrast to what we have been practicing, the cross regimen. So these are two concerns. Okay, Safalta, anything more to add? Sumit, you were saying something?
Cross was weekly, sir. This is 3-weekly regime.
Yes. So again, you have put forward the third point of the weekly versus 3 weekly. So, Safalta, do you agree, disagree, and do you think, if I can take this forward, because he has pointed to what exactly I felt, is that weekly versus 3 weekly is something which
Yes.
I was little not okay with it.
So
So,
I
do
agree on all the points of Dr. Sumit, and probably they have added nab-paclitaxel because in Atizo trial, one it was okay with nab-paclitaxel, but not okay with paclitaxel sort of because Dexa was used. That sort. So likely they wanted to negate that effect for with
so
sintilimab.
not to give steroids. That is the
Not to
point why
give
they use
steroids.
the
That's why
nab-paclitaxel.
probably they have added nab-paclitaxel rather than
Okay.
paclitaxel.
Vamsi,
But yes, I
weekly
agree
versus
with.
3 weekly. Do you ever practice on a neoadjuvant with concurrent radiotherapy once in 3 week schedule?
No, as of now, we are doing weekly,
Okay.
or else we would get the only other exception would be the CIS 5FU, which is the 4 weekly.
Yeah.
I don't practice.
Okay. So to put forward, the panel has rightly pointed out, I felt that was the most stark thing that could come out. And once you see the protocol, and if you look into the data set, you do find that the cross is the standard of care. And from since let's say 1.5 decade, we have been practicing a weekly paclitaxel carbo at least for a decade. And the only once longer schedule is what Dr. Vamsi spoke about, is the weekly cisplatin 5FU, and that is a different thing, and none of us practice that. Anyone that practices the 5FU cisplatin even today when you're doing a concurrent RT?
Sir, probably in a fit patient in upper CA esophagus.
Upper
Yes.
esophagus. Any specific reasons? Because you have a much more radical intent of RT there. That's the reason?
Probably, sir, because that
Okay.
is the hope
Okay.
to
But if you have a mid esophagus or a lower and you find it to be a neoadjuvant intent, 41.4 gray, and it is weekly paclitaxel. That's it.
correct, sir. Yes, sir.
Okay. So I think that is well pointed, and I think that was what really my thoughts were. Okay, Safalta, what do you think? This trial had a immunotherapy with the in the neoadjuvant, both in the arm A, which was only with chemotherapy, and also in the other arm with concurrent CTR. So, do you have something to say on the role of immunotherapy? Do you feel it was a well-intended trial, and do you have any precedents to speak that this was a trial that was required? Safalta? Yeah.
Yes, sir. So actually, like immunotherapy has come up in everything. It has been tried in cervical cancer or head and neck cancer along with radiotherapy. So probably they have thought to add up some more responses, more PFS with this, adding immunotherapy to this trial,
Okay.
to esophagus also. So that's what I thought of.
Okay. So, once you can take it forward. So, basically, the point is because in the metastatic cancer, it has shown its efficacy. You did find the adjuvant data set coming up in nivolumab, so that was there. So that is the reason why they did it, and it is the only way forward. That is the best thing we have in our armamentarium to increase the possible oncological outcome. It is a fair way to conclude that that is the reason why you have looked at.
Yes.
Yeah,
Yes.
absolutely. So, you see, you would want to improve your outcomes always. So, adding
Okay.
it makes sense. Whether it works, it's a whole different way when you compare to head and neck. In head and neck, so far, it has not worked.
Okay.
Conversely, when you look at squamous, we do have the A18 now, which says it works. So,
Okay.
it's a mixed bag, really, right now. Trying it is okay.
Okay.
With a phase 3 study, I'm actually more interested in numbers. Only 45 patients in each arm,
Exactly.
50 patients. It's a small number. So,
Yeah.
that was something that struck me, that you're calling it a phase 3 multicentric. And honestly, at least for if you really wanted a very good trial, you should have included a next kind of study, because the JCO, that Japanese study next, is quite decent study. If you cannot give CTRT, that's also a good option to give.
So my point also was for the study. It just came through. You put the numbers. That was a concern which I would have put it in the last. The second most concern is it is a single country multicenter, and then you are little skeptical, and that is the main problem with most of these drugs that come out of that particular country. Do you have a concern, Mamsi, on that regards? And then Sumit, you can, because this is our future, because these trials are coming and they're coming every month now, and these drugs are going to be available very soon in our country. So do you have concerns that these drugs have not been tested anywhere outside? Most of the trials have been done in a single country with a single ethnicity. Is it a concern for all of us?
Honestly, the population which we are following, the Western population, is quite homogeneous. So, you have a trial done in Australia, Europe, America. All those are a homogeneous, more homogeneous population.
So these particular drugs,
So
the
that's
new
what I'm saying. So
Chinese
what I'm trying to
immunotherapy
say-
that are going to bombard the market in few weeks, months now.
What I'm trying to say is when you didn't have a problem with that homogeneity,
Okay.
purely because it is coming from one country, I am not too worried about that.
Okay.
It's like saying a trial which has been done in India, we will reject because it's done only in India.
So
that
you don't
I'm not
have a
too worried.
concern as the normal Western world has, because can you assume they have their own motives to have the concerns, so-called concerns? Safalta, your take, and Sumit first.
Yes,
Sumit,
sir.
what is your take on having trials from a single country?
I will be little apprehensive, especially the where this study was done. So definitely data from other centers, like other countries, apart from this particular country, it will be little more reassuring. Again, as Dr. Vamsi said, the numbers are very small to make conclusions.
Okay.
And third thing is the endpoints that we are looking at, sir, is whether they will translate into what we are looking at, what we want.
Okay. So as I think I am in between. My point
One
is,
one thing is
please,
that
Safalta, you speak.
see, if we invent a drug, okay, and we test it in Indian population and show good results, it is not that other countries will start using it.
Mhm.
So they will be skeptical that Indian drug, and they have just tested in the Indian population, that nobody will be believing in it, in that drug. So it will be like we also, and that too, that country which is China. So we cannot believe in the China made
I
things.
don't think that is the way to put it forward. I understand the reservations most of the people have. The problem is not the country or the drug. What I feel is that once you get into phase 3 and you intend to market it to the world, you should have run a multicentric trial with the multiple countries. And the point which Vamsi made, I think that's partially incorrect, that most of the drugs which have adopted immunotherapy are multi-country trials, where they've taken across the globe, where you have people from Europe, the North and South America, and Asia. So it's not that they have done a single country. I don't feel one of any of these 3 or 4 major drugs which were used have been a single country trials. But the problem with these Chinese immunotherapy drugs have been majorly they're only one country trials, and we know people would like to see their efficacy replicated outside the country. I think that is the only small point, but agreed. But the efficacy and the data set looks quite strong. The numbers apart. Okay, now move
One
on.
thing I
Yeah,
wanted to point out, say,
yeah,
radiotherapy causes lymphopenia.
yeah. I will
And
come to that. I'll come to that.
okay,
We will discuss that. We will
okay,
discuss.
okay, okay.
Okay. So now second point. Let's move forward. We had this talk. We had this discussion of the things. I will come into a more pertinent point, because PATCR is the primary endpoint, and fortunately or unfortunately, it is the primary endpoint for most of the new adjuvant trials. We like it. We may hate PATCRs as an endpoint, but that is going to be there. Vamsi, do you think, if I take the example of gastric cancer, and we had a last year, it was all about gastric cancer new adjuvant, and we learned that PATCR does not translate into oncological outcomes. So are you skeptical that these paths here which are increased will not translate, especially we don't have this data from this trial?
So again, your point is well made with regard to gastric. We don't know if it is the same in squamous esophagus, and I agree with you. Just using a PATCR as an endpoint is not particularly valid right now. I don't think anything beyond probably the
event-free survival is something you look
Yes,
into,
I would look
maybe
at
the
that.
OS ultimately.
Yes.
Okay. Other two panelists, any comments on the PATCR thing?
No, sir. That's what I said, sir. The endpoint that we are looking at, whether PCR will translate into benefit, we do not know as yet.
Okay. So are you, as an oncologist, when you give neoadjuvant, are you happy when you get a PATCR? Because ultimately, all said and done, intent to treat, it may not work. But we know if you achieve more PATCR, that particular patient does very well.
Agreed, sir. Definitely, yes. If we see a PCR, it makes somehow we feel happy about it, and everyone feels happy about it.
Okay. Safalta, I'll take it forward. What I get the best thing was trial, with all the criticism we have done, one silver lining on this trial I can find out is it gives you an option of giving a shorter course of immunotherapy. The same thing which we discussed in lung cancer with nivolumab. So here you are giving a much shorter course of immunotherapy for 2 to 3 doses. And once you
Yes.
have a PAT-CR,
Hmm.
which is pretty high in this trial, you
Yes.
are not going to give anything other than surveillance. Does it
Yes.
not make it attractive? And you would love to see this on a bigger set, probably on a multi-country trial, and then probably it makes sense to not give adjuvant nivolumab for a longer period of time, rather than
Yes. Yes.
just give it at a shorter period, and only if it does not have a PAT-CR, probably think of something else.
Yes, and this trial gives you a food for thought for all the malignancies in which we are using new adjuvant immunotherapy like breast cancer, and then we'll be getting some data whether we have to continue that immunotherapy after PET-CR. So
Okay,
this
fine.
study has this plus
So
point.
this is one positive point. This you feel that PAT-CR, if you achieve actually the
Hmm.
nivolumab data set, if you achieve a PAT-CR, you did not give nivolumab anyway.
Yes,
So
yes.
that could be one similar. Vamsi, your thing on this, and can you take this question? Would you offer, may not be this drug because it's not there, maybe once it's available, or would you offer on this data set probably a nivolumab like thing, and especially for squamous cell, and especially if there's a PDL1 which is more than 5? Just translating what you see in metastatic to the neoadjuvant intent.
So two sets or two parts to your question.
Yeah.
Number one, at this point, it is not practice changing. I would not
Okay.
practice this.
Okay.
Number two, second part of the first answer is that we know that all immunos are different. We cannot correlate and say just because this worked, I'll use another immuno and it will work. We know that immunos don't
Then
behave.
the PD1 thing would not matter to you much.
Correct. That is one.
Yes.
Second part of your question, PDL1 is just not correlating, I don't think, anywhere with PAT-CR. It has correlated with responses, with survival.
Oncological outcomes.
Yes, pathological outcome, including lung, where it is being pushed so much. There's no benefit of doing PDL1 at all.
Yeah. So
I
I
believe
was coming to
PDL1
this
matters.
point. If you look at cross trial, Vamsi, and look at the cross followed by nivolumab adjuvant, and look at that data from 577, if I'm not wrong, and look at the data. If there's PDL1 more than 5 and higher PDL1, the PFS is extraordinarily high. So basically, it is looking in and going in the same line as we see the role of nivolumab with chemotherapy in the higher PDL1 in the gastric GE junction and esophagus actually. So I was pointing towards that. We move gradually and slowly towards probably super selecting our patient. That's the only small point. I agree it's not practice changing. I agree to that point. Okay. Sumit, your take on this practice changing part?
Sir, I agree, sir. I will not consider it as practice changing at this point of time.
What will take for you to change practice?
It needs to translate into some meaningful benefit for us so as to convince the patient. As you
So
said,
tomorrow, if there is event-free survival which is statistically significant, would you change practice?
We will think about it, sir. But still, there is another thing, sir. See, the comparison that has been done is Group A versus Group C and Group A versus Group B. But we do not know whether there's a comparison between Group B and Group C.
Group B and C.
It was added with.
So basically, we wanted that comparison to be there.
Correct, sir.
So we're coming to a larger point. Again, one more flaw that has come in. Basically, if you look at it, all of us agree CTRT is the standard. So
Yes,
we should be thinking of adding something to the CTRT rather than neoadjuvant, because that is only practice when the general condition is not appropriate for you to give a content CTRT.
Yes, sir.
That's the point you're making. Okay.
Yes.
Safalta, I'll come down to what you probably intended to tell. Can there be a better sequence? And do you have evidence for that, or is it just the theory which you are going to quote? Safalta? Is he there?
Yes, I'm there. I'm there.
Yeah. So you wanted to speak about the sequence and the lymphopenia. So what were you suggesting that?
So what happens is that because radiotherapy causes lymphopenia, and when we add immunotherapy, which actually works with the help of T lymphocytes, so when there is already lymphopenia, how can it be working better with the combination with radiotherapy?
So what do you propose as a sequence? It's a good theory. It is people have proposed that chemotherapy does a lymphopenia, and you need the immune checkpoint, the T lymphocytes to be active.
Yes, yes.
So what is the sequence you would propose?
So I would like to go ahead with the CTRT followed by surgery, and then if at all like nivolumab in the
Okay.
adjuvant setting, if it
Any
is
one
like
of the two other panelists have some idea on this? Because I did not preempt that she will ask me this, but I had this. And there is one more subside which I'll speak on, which there is some data on the sequencing with CTRT. So Sumit or Vamsi, any thoughts on the sequencing? Which could have been a better sequence?
At this point, I think the best evidence we have is for CTRT followed by nivolumab, followed by surgery, followed by nivolumab, and that's should be the standard of care.
Okay,
So
that's done. So
anything you
what?
want to add has to be added onto this. You could
Yeah.
not.
So something I wanted to pick up from the head and neck cancer. And if you see, there are 3 now big trials. Sumit does quite a bit of head and neck, and I will ask him his point. And this the beauty of this is, if you look at the concurrent, there is a data from Nivo, Avelumab, and now Pembro also is there. So 3 immunotherapy for head and neck. There's a beautiful data, although small data set, of concurrent CTRT with immuno versus CTRT sequencing with immuno. And they found that sequencing is better, especially with that theory which Safalta spoke about. So I'm not telling that it will change practice, but I won't be surprised if tomorrow we have a CTRT cross-slide followed by 3 cycles of immunotherapy and then surgery. If
Dr.
that
Sahu.
could be, yeah.
Dr. Sahu, lung also same thing we have seen actually. If you see Pacific and Pacific 2,
Yes.
Pacific 2 is negative, possibly because of that. We don't know.
So I was coming to that point that the theory goes that you are killing those cells actually, which actually would be helping immunotherapy. So this is the only point which I wanted to speak about this trial. Any one of you want to speak something on this study, science study, before I switch gears? Anyone? Sumit?
Sir, I think what you said is there is some data of Sintilimab plus chemotherapy as induction followed by chemoradiation.
Yeah. So basically, don't add it to the radiotherapy chemotherapy part.
Probably, sir. But if you need to add to be, maybe it induces the hypoxia, increases the responses, but that is all theory. But we need ultimately the data.
So I will conclude this part with that this abstract is very interesting. It definitely gives you a lot of food for thought. And before we shift gears to the second abstract, it does give me the thought that the path CRs are increased. We do have more responses. Does it translate into oncological outline like EFS or OS? Time will only tell. The numbers are small. It's a single country multicentric trial. That is a worrying point. The point is, can it be sequenced better? It is the future trial will only answer this. But yes, it is definitely interesting trial, and people are looking at increasing path CRs, and they are going to add things to the CTRT to increase the path CR, and probably that will reduce the number of patients who will ultimately receive a adjuvant immune checkpoint. So with that,
I want to add something.
Yeah.
So they have compared it with only chemotherapy plus IO arm. But when you see the two arms, when there is CTRT was given, then in that case, confidence, though the number was 47% and for 60%, but then when you see the confidence interval, they are crossing each other. So if they have compared, they would have
with these
compared
numbers,
these two arms.
Safalta, everything will cross each other.
Yes.
The numbers are too small
Too
for
small,
any
yes.
benefit to come out.
Yes.
Actually, that's
Yeah.
what Vamsi picked up, and all of us have agreed to that. But this concept is interesting. I definitely people will go with the standard immunotherapy things, and this are going to be the future. And actually, if you look into the article which I actually wanted in the group in the morning, there are multiple trials actually going on in this segment. And I think the next 2-3 years we will have a clarity on how to go forward. Okay, so let's go forward because we have limited time. And this is a Dragon 01. All of us know this. Quickly put it in. It's intraperitoneal and intravenous chemotherapy with Pacli plus S1 versus only the way we practice. And this is a chemotherapy with Pacli and S1 as a parenteral, nothing into the intraperitoneal. And this is for patients with only peritoneal metastasis with gastric cancer, and that is the randomization. Again, a Chinese trial. So, Sumit,
Yes,
do you
sir.
practice any form of interperitoneal therapy in this setting, means the advanced metastatic setting?
No, sir.
No.
Not at this
Vamsi?
point. Not yet, sir.
Vamsi?
So there is a study which came last year, ASCO, which was negative. So we know it is negative. So my interest is less. As of now, I would not be willing to select anybody.
In that patient, in that study, it was only the retroperitoneal node group which was positive. So that was the study.
Correct.
So here, but here they did not, they went for chemo and surgery alone. Here they're giving something as intraperitoneal actually. So there is a difference between both the studies. That was a German study which we are speaking of. So, and this is Safalta, same answers from you. You do not practice this?
Yes, I do not practice. I don't intend to after the study also, because here the comparator arm is like non-platinum comparator, paclitaxel with SN, which we don't practice. They should have added one platinum, like Phoenix JC study. So the comparator arm was cisplatin along with S1. There it did not show any benefit. So I will not intend to
Okay,
use
so
the
I will
paper.
come to that thing, but the conversion for surgery indications were pretty clear. They wanted all the disappearance of peritoneal metastasis. The primary tumor should be resectable. The cytology should be negative and no other distant mets. Very quick question. Vamsi, and Sumit, both of you can quickly tell me, in your practice, how many of your patients with advanced gastric cancer have only peritoneal metastasis or ascites and no other disease anyway?
That will be around 20%, I would say.
So
15,
around 10 to 20% is a fair
20% might have it. But again, I mean, if you ask me whether those patients would have had some nodes or some other findings if you did a surgery, I really don't know. I mean, this is based on PET that I'm saying.
So it's around 15 to 20 for you, Sumit?
Maybe less than 10%. They have only
10%. Safalta, for you, any different numbers?
Almost 10-15% patients
So it
only.
is a minority of 10% to 15% is a fair assessment from the panel. This is the trial which you spoke about, Safalta. And if you look into this trial, there's a beauty. It was a negative trial. Agreed. But if you look and study the full article, there was there was analysis, and we can tell it's a post hoc analysis, exploratory analysis. But they looked into something based on which this trial was taken actually. And if you look into, they looked into and found that if there was a peritoneal disease predominantly and only, then you had a benefit of intraperitoneal chemotherapy, and that based on that background, actually, this trial was suggested. So, is it practice changing? Safalta has already told no. Vamsi, it has a OS benefit. We always speak of OS, OS, and OS. Would you at least consider, and patient should be discussed about intraperitoneal type of treatment, basically for the 10-15% of these patients? Do you agree that that can be a point forward?
So, first of all, the mathematics is slightly not correct. It's not 10-15% of all patients. It's 10% of this 10% who completely respond to therapy. So they have said that peritoneal metastasis.
Agreed. Let it be even 5%.
Fair
Do
enough.
you feel there is a patient group which you will tomorrow start counseling for a surgery post a response?
So in practice, we do consider some patients who have had a long disease-free period, supposing 8 to 10 months without any disease, for doing a surgery.
But not for these patients.
Yes. No. So surgery we would do in those
Okay.
patients who had only peritoneal disease to begin with.
Okay. But you
whether
would
I
not
would
consider
add IP,
intraperitoneal therapy.
yes, I would not add intraperitoneal. CRS, I'm still thinking is okay. IP, as of now, I am not convinced.
But CRS, if I go back and see the German trial, actually for the peritoneal lymph node disease, extra retroperitoneal, nothing else helped. Even the peritoneal disease, the surgery alone did not help.
Correct. So that's why I said we won't do it in every patient. Supposing you do a skip the chemo, there is 6 months gap, nothing else is there. Patient has only some stomach thickening remaining.
So you're telling for the very good patients, like
Correct.
we do in RCC.
Very selected, very good, not like a standard of care.
Sumit, it is not that bad a trial. We always speak of OS. And I get it from both my panelists who have a good experience in GI, that they are not pretty happy with this trial. They have still a lot of skepticism. And this trial is actually the predecessor trial which was spoken, which was a negative trial. And in Phoenix, you get this trial to based on, it's actually extension of the Phoenix. We got to know that the only peritoneal disease is different. They respond good to intraperitoneal chemotherapy. And that is why this trial was designed. So with the OS benefit, why do you not do it? And the OS benefit has come after 5 years. It's not a short benefit we're looking at. It's a 5 years benefit.
So, sir, I have my points. We will discuss as we go along. But I have, at this point of time, if we are starting this study, I'm interested, but I will not say whether I will commit or not, because as we move on, we will discuss, sir.
Okay.
Second thing, the important thing for me here is that the dose of S1, it is 80 milligram per square meter. The recommended dose in advanced stage gastric cancer is 25 milligram per square meter as per the product, the label. So 25 milligram per square meter BD is 50, but 80 is too high for me. I don't know whether non-platinum, because of the non-platinum agent, the patient is able to tolerate better or not. But that is one issue here, sir.
Okay. So you are happy with the paclitaxel dose of 70, or do you feel it should be little more?
So paclitaxel weekly 50 milligram per square meter.
That is with radiotherapy. That's with radiotherapy.
Yes, sir. But this
You don't give, when we give paclicarbo only in metastatic, we do 80 per meter square with AUC 1-2 of carbo.
Yes, sir. So maybe 40 milligram per square meter or 50 milligram per square meter. That is what they are.
So you would still
IV paclitaxel here
give it for
in the.
Okay. So here I want to take
Yes,
it
sir.
forward for two things. Why paclitaxel? Can any one of you put some light on it? Because there will be some students who are looking into this. So why paclitaxel? Why was this drug chosen? Anyone has idea?
So we have the prospective study extrapolation probably from ovarian cancer, where the Deborah Armstrong studies are there, sir.
So actually, why paclitaxel was chosen, I'll tell you. They're very beautiful on that on the last article which we spoke about in the negative study. It was actually pacli is more acting on the surface of the peritoneum, and it causes less adhesions. So surgery is much better, and the reason is that is why you have to give something which is more frequently it can be given, and pacli actually fits that criteria. So it does not cause adhesions, which most of the other therapeutic drugs will cause, and that is one of the major reasons why pacli is chosen, and that is the reason it can be also given multiple times. So this is the particular reason why pacli is chosen, and that is the one important point which we should know. Okay, let's move forward. If we have 5 minutes on this study, so now tell me, I have two concerns. Anyone has any other concerns, and or we should we discuss only these two concerns about this study? Vamsi? Yeah, Sumit, you want to go first, please.
So the concern about this study is, see, they are talking about R0 resection, not about pathological CRs or what did we achieve. So doing R0 surgery only is translating into the OS benefit, which is like if you are achieving R0 resection by chemo alone, not IP, then it is not translating that much. But the R0 resection, it means the intraperitoneal paclitaxel is doing something, but that intraperitoneal paclitaxel dose is very less. At the end of the day, we do not know whether it was converting into PCR rates.
This intraperitoneal pacli dose it is accepted doses actually, because you are giving also IV along with that. So basically,
Understood,
you are able
sir,
to achieve much higher doses without toxicity.
They have said R0.
Maybe, come again.
It is. But they are saying sir, R0 resection, not the pathological CRs or major pathological responses. So doing R0 resection.
Pathological responses were also a criteria which I'm putting here. The secondary endpoints were conversion surgery rate, path CRs, and adverse event. The primary was OS, as we spoke about.
Okay, sir.
Okay, so anyone, Vamsi, you want to have a talk on the signet ring cell, which is very much skewed for the non-NIPS arm.
Yes.
Any points on that?
I mean, with 7,448 patients, it's difficult to comment much. But yes, signet rings don't do as well. So definitely that being like so is a bad thing.
Should have been a stratification factor. What I meant
I'm
to
not
say
very
is
happy. They should have had at least somewhere close, 45, 50, at least 2-3%.
Maybe 39, 42 would have been a much better than 39 and
or
50.
47, 50 would have been better.
Yeah. So that is one concern. Can I ask someone, because I don't have that amount of practice for gastric going into HIPEC or other PIPEC or something. So is it that they look at the PCI and anything around below 6 to 10 is something they are very much interested in intraperitoneal therapies, and above 6 or 10 they are not interested? Safalta, is it the way you practice in your center, or any PCI index is also okay with you?
So I don't practice intraperitoneal chemotherapy anywhere. So I don't practice ovarian cancer. So I don't have any idea about this. Yeah.
Vamsi or Sumit?
It's a PCI.
Yeah, go ahead. Sumit.
Yeah, PCI score too low, probably HIPEC CRS is not beneficial. PCI score too high, it is not beneficial. So it has to be optimum. What we do is look for the numbers around, I'm not remembering, it is about 10 to 16. If it is there, probably we proceed with HIPEC CRS.
Vamsi?
So again, this numbering is not easy. It's more of a,
It's difficult.
surgeons take a call on how much it is.
Yes.
But I agree, if it is, we would be happier if it was less. I'm not sure if it is more, it'll really benefit.
Most of the guidelines have put it around less than 6, and some have gone to 10. And this trial actually had most of the patients which are beyond 10. So there are issues, but definitely most of the thing which I want to say is that chemotherapy does not do well with signature, and that was heavily skewed towards chemotherapy alone. And that is something is a concern. This is the data set. All said and done, it's a positive trial, and the graphs do separate until quite long. Ultimately, it's a gastric cancer. Most of them will relapse, and the hazards are pretty impressive actually. If I look into the statistical heterogeneity was not significant across. So basically, every patient type actually benefited. But I have only a small concern whether you did a conversion surgery or did not do a conversion surgery did not matter. You would give it to everyone. That is how this statistically you would conclude. Any of the panel want to say it? So basically, it tells you do intraperitoneal. If you can convert, well and good. If you cannot, also it does not matter, because the forest plot, it tells you that it was anything was good, it was okay without or with conversion surgery. So Vamsi, would you read it differently or would you read it the same?
I mean, the reading is the same, but practically speaking, I think this is, splitting hairs.
And if you look into it,
Yeah.
this is something different in the graphs.
Yeah.
If you have a conversion surgery, it's excellent. If it is not, it is actually doing very poor. And
No, so that's what I'm trying to say. The conversion failure you have used in both the arms comparatively. You have
yes,
not just done in one arm, right? So,
yes.
and there also, if you have given the NIPS, it has slightly benefited more, is what
But the hazards is nearly same, 0.24, 0.31.
Yes, but it's splitting hairs. I think it's
So
really
basically, if
not
you have a
number
conversion
enough to
surgery,
say
they're
that.
telling it's good. The only
If
point
you
is,
can convert it, good. If you can't convert, still there is some benefit of adding NPS, is what they're saying. But then, what is that benefit that we want? I mean, that small hazard ratio benefit is different, but you see the absolute numbers, it will not be much.
yeah.
That's
So
what it is.
basically, I also get one fair point from this, that 50% get converted to these surgeries, basically fulfilling the criteria if you do the NIPS. But if you don't, then one third will be getting a surgery, as Vamsi told in his patient selection group, and two-third would not be getting. So basically, lesser patient do a conversion surgery if you are not adding the intraperitoneal. But my problem is this, that the p-value was not significant for the heterogeneity for conversion surgery, whether you do it or not. So there's a dichotomy which I felt with that point of thing. Even the histology did not matter. I was little surprised that the clear cell, the mucinous or signaturing did not matter to, and that was something which I felt was not okay. And the last point, I would love to have a peek into the post-progression therapy, which I could not find in this study, because you are looking at OS.
The other thing is, they have not talked of HER2, they have not talked about immuno. Obviously,
Agree.
that time
So,
when yeah.
control arm was chemo with
Yes.
immuno. I wanted to put it across, but if you look at the survival which is there for the patient who had conversion surgery is actually 33 months. And actually, I looked into median survival with chemo plus immuno, it's around 15 to 17 months. So that's why I did not put it in the main discussion, because if this is true study and if it stands the test of time and the second study replicates it, Vamsi, we are looking at doubling the survival than what we can get with chemo plus immuno. Although I agree, today's control arm should have been chemo plus immuno. That's all that is done. Data appears impressive to me, but has opened up more questions. Should it be offered to appropriate patient? The panel thinks no. Only Sumit felt he might think of running a study in his center. So coming last 3-4 minutes to Aspen. Again, interesting study. So any concerns about this study? Sumit?
So Aspen, basically it is if you look at the schema, sir, it contains multiple drugs. You will remember, sir, there was a wise man who said whether he used this comment for something else, whether we are giving induction chemotherapy for leukemias.
Okay. So basically, you're not happy with the regimen that is being used, triplet things. There's 2 targeted therapy plus 1 chemo.
Yes. Again, sir, it is basically re-challenging the trastuzumab, because in this study, all the patients had received prior HER2-directed therapy.
Yes. So you are not happy with the re-challenge. Sapalta, can you be more specific? What exactly is not a good thing about this study?
So what I felt the only interesting thing I found is the mechanism of action of this new drug.
So you got to know the new drug as a new mechanism of action. It works as a immunotherapy also. and
Huh.
also want the immune cell to recognize the cells and can kill them.
Yes,
Basically,
yes.
that's what it is.
So,
Vamsi,
hmm.
I have issues with the archived biopsy being used.
Yes, and then ctDNA and fresh biopsy, that was
Okay,
very
but my
confusing.
patient, but my concern is 30% or more had only archival biopsies, tissue HER2 positive, which was used to give a trastuzumab. Is it a concern for you, Vamsi?
The change in HER2 is around 10 to 15% as per the trials we have in gastric. So yes, it's a concern, but is it that big that it will completely change
This
your
is
thing?
it.
I think not
This
so
is
much.
it, Vamsi. The
Yeah,
change is much more than that.
20 to 30,
Actually,
25%, not more
yeah.
than
So if you look at the 100 goes to 30% only. There's a drop of 70%, and that is why you did not have the trial positive when you continued trastuzumab. So basically, you need to have a biopsy, rebiopsy, and if it is still positive, only you give it, and that is the standard of care actually. So there is a issue with the archive versus fresh. So in gastric cancer, Sumit, is it what you always do? Do a fresh biopsy, and if it is HER2 positive, only challenge it with a HER2 agent?
So yes, probably because that's what we have been told. Ki once you use the trastuzumab in first line, there is loss of expression in the subsequent lines.
So it's
So,
very different from breast cancer actually.
correct, sir.
This is something that people have to know. And I have issue with the archive tissue being used, and 20-30% are archived. And interestingly, they did not share the data on what happened to the patient who just they did it on archive tissue. Because if you look at it, one third data is missing here. They only concentrated on a ctDNA versus the fresh or fresh biopsy. So they wanted to compare a biopsy fresh versus combining fresh biopsy ctDNA, but they did not have a third arm which was on archive tissue. I hope you all of you are getting the point.
Yes,
My
we are
last
getting.
question. My last question. Do you do ctDNA for HER2? Because the concept comes from that if you do a biopsy, a small biopsy, you would not be having the heterogeneity of the tissue. There will be heterogeneity of the tissue. It won't. You may be selecting a segment which may not have HER2 expressing. A ctDNA would be looking at the shed HER2, which would be more representative of the presence of HER2. Is it a better way? Vamsi, what is your take on it?
difficult again because your ctDNA will look at both the mutations. Then you need to specifically make sure you're looking at the amplification of HER2, which is not so simple. So again, for those who are listening, it is not every liquid biopsy is the same. You need to know what you're looking for. So
Yes.
practically speaking, it is difficult. If you have a very good liquid biopsy, which is catching everything, then I'm fine with doing a liquid
So
biopsy.
basically, what Vamsi is saying is, it will take care of the heterogeneity which happens across the tissue. You in a biopsy specific may not have, and suddenly ctDNA you may have it. That's because of the shedding. But you should have a liquid biopsy lab which has the capacity and the quality checks to look at the amplification. Is it right, Vamsi?
Correct, absolutely.
Okay. So basically, it tells you that if you have it, then it really does not matter. So basically, you need to look at HER2 new in the biopsy fresh, or at least the ctDNA, and in a good lab is the message which goes through. So I'll just conclude and just have one small point on this trial.
Sir, can we go
Yeah.
one slide back, sir?
Yeah,
Two
please.
slides back. The one slide back, sir. The previous one, sir.
This one.
The previous one, sir. Where you
This
had
one on the trial one.
yes,
This one.
Yes. So how I look at it, sir? See, my interpretation of this will be: suppose I have to use this new drug, which is FC inert, basically. Evo prep, the difficult name, sir. The Evo one. So
ever present.
so if you are having a biopsy which is showing positive, then it is okay whether we use Evo or not. But if it is like we know ctDNA is positive, it's better to add Evo.
Yeah. So basically, you need to conclude the positivity of the HER2 still persisting in any form. So that's what.
Correct, sir.
Yeah.
But you need to be extra sure if we are not using this drug. So then we need to be very sure that yes, this is positive.
And then second point which I have a concern is now TDXD is the go-to drug. So it has not compared against TDXD. We do not know what will happen.
Yes, sir. Correct, sir.
And the OS with TDXD is around 12 months. My last take, would you add, Vamsi, do you give neoadjuvant therapy to operable gastric cancer who are HER2 positive?
As of now, I'm not differentiating. I am giving. I am not
You're
differentiating within trust.
So what is your regimen you're giving?
I am giving FLOT as of now.
FLOT. So only chemotherapy.
Yes, only chemo.
Safalta, just a last question on this. Why not add immunotherapy and trastuzumab to the chemotherapy plot.
Yes, that this will be very interesting if you add, and it will show, because like colorectal carcinoma, it has shown that when you add these two drugs. So yes, it will be very interesting to add.
Uh, Pamsi, can I ask you a provocative question? Because I speak to you a lot, I know more of your practice. In gallbladder, you told me in HER2, in frontline, you'll use it because there is evidence later on. And you'll use the gastric way of doing immune checkpoint plus HER2 targeted plus chemo. Am I right?
Correct.
So why you want to use it for neoadjuvant to because you have a proof of gastric cancer that immune checkpoint, especially in the PD-L1 positive, would be more important with trastuzumab and chemo. So why not add FLOT plus trastuzumab plus immune checkpoint?
Because the keynote study was negative for neoadjuvant pembro. The Matterhorn, it looked only at the PCR, and you don't. And there's one more trial that I'm not getting which
Yeah,
name.
yeah.
It's Nevo trial.
Keynote
Use the PCR.
811. Keynote
So they are
811.
basically negative trials for immunotherapy in neoadjuvant gastric. So till I get a positive study, I'm not going to start immuno in the neoadjuvant gastric.
Okay, point taken. So basically, to cut the things and conclude, what I wanted to say is, if you look at this study, it shows you that addition of a dual HER2 did not add much to a single agent. So at this point, we have to be very skeptical, and I think still believe what the panel shared, that FLOT remains the gold standard. If you want to do something beyond FLOT, I think you have to do it out in a trial setting or with a due consent taken. Sumit, fair enough as a conclusion for HER2 positive patients?
I agree, sir. What you said, I am not convinced for float at this point of time. If it has to be it has to be done in the clinical.
So it's a FLOT only for you as of now.
Yes, sir.
Okay, so here with that I stop. Sorry for taking 5 minutes more of your time, and I hope all of us have learned little more on these street studies. And thank you, being lovely discussants. And I think I've also learned a lot from all of you. Thank you, Vamsi, for giving us all the opportunity.
Thank you, Dr. Sahu. As usual, a very, very nicely discussed. I initially thought with 3 abstracts, we may not have much discussion, but you brought out so many points in that. So that was lovely. Next panel discussion will be by Dr. Atul Sharma, sir, who we all know has been in AIIMS and presently is the Vice Chairman of Medical Oncology at Max Healthcare. So his discussants will be Dr. Vijay Agarwal, who is medical oncologist from Apollo Hospital, Bangalore. Dr. Bivas Bishwas, who is the medical oncologist from Apollo Cancer Center in Kolkata. Third person was supposed to be Dr. Krishna Kumar, who couldn't unfortunately join us. So Dr. Sahu, Dr. Safalta, Dr. Sumit, and myself will pitch in wherever feasible. So Dr. Atul, sir, over to you.
All right.
Sir, a request, just bother those two first panelists.
All right. All right. I don't mind leaving everything to, I think, maybe Vamsi.
No, sir. It's just it.
All right. So I'll request, so shall I share or maybe that somebody else, I think do they have the...
Sir, if you want, you can share your slides, sir. Otherwise, I will do.
All right. If they can do it, that probably, let me see. Ram, can you share it?
Okay, sir. Okay. I'll do so.
All right. So unlike the gastric and gastroesophageal, probably personally, I have been sent a couple of abstracts, but I did few others and this thing. I didn't find it. Personally, it was good for me because I got a chance to present our oral data of chemoradiation. But there were a lot more could have been. I think most of the study were either in the hepatocellular, which are not included because they're supposed to be BTC, or maybe some in the pancreatic cancer. So I just probably manage with this thing. I am just going to discuss about the BTC only. So maybe that, since anyway I have the Bivas and also Dr. Vijay Agarwal is there. So probably maybe start with something which is probably very, very basic. most of the time when we see these kind of patient, maybe it may not be uncommon scenario when they present with obstructive jaundice, biliary dilatation, and this thing. So there was this particular abstract with regard to navigating the biliary blockage. So I would like to ask maybe that Bivas, you can start. What is your practice with regard to this thing? Do you find one after the another, one better than the another? There are different approaches.
Uh, Sir,
We
so
can go to the
most,
next slide, please. Maybe that
yeah,
will be easier. We can go to the this thing. So next one, please. So we can come back to this. Yeah.
yeah. So, whenever we treat, be it cholangiocarcinoma or gallbladder or pancreatibiliary in the study of obstructive jaundice, so our usual approach to do imaging, proper imaging, and then send a referral to our gastro team, mostly for ERCP and stenting. So, endoscopic stenting is our most preferred way as of now.
So
But
is
there
it
are,
endoscopic better than the percutaneous or vice versa?
I cannot say, sir, better. Cost-wise, logistic-wise, percutaneous is better. But many patients do prefer endoscopic stenting. So I think mostly our gastro team take the call depending on the level of obstructions and also the patient preference and logistics, the cost and everything. But majority, as I said, majority is here it is endoscopic stenting.
Okay. So basically, I don't know. Maybe somebody else wants to comment on this, Dr. Vijay.
Yeah, so I think it's by and large most of the patients who end up coming to us come to us after having had these procedures rather than we having to decide them. But having said that, I think the location of biliary obstruction also matters a lot. Now, if it is periampullary or distal CBD, I think most of them end up with an ERCP and a stenting there. But if it is hilar or a bit more proximal to that, then I think they end up with percutaneous PTBD and followed by stenting in that. So I think a lot would depend upon the location, and of course, a lot also depends upon whom they end up with. Do they end up with the gastroenterologist
A radiologist.
or a radiologist? And I think, and of course, the facilities available at your center. Not every center has interventional radiologist doing percutaneous. So I
So
think there
this
are
was,
various factors that
go ahead.
there are various factors that take into consideration. But if I have to take a choice, I think distal CBD is probably endoscopic, and the more proximal ones probably percutaneous.
So I agreed, and that probably you're kind of the spot on. Basically, what I wanted to highlight, because basically it also depends upon the team. If they're the gastro team, probably they might be towards the endoscope ERCP, or if they say the IR or oncologist, maybe PTBD also. They personally, I reviewed this thing, and there are very few studies with which have compared these two methods directly, and they have involved very small number of the patients. Can we go back to the previous? I think let me try to have control of this thing, becomes easier. So basically, obviously, whatever you do for the younger colleagues, biliary drainage is one of the common phenomena or requirement before we start these BTC patients on systemic treatment. Endoscopic drainage, they say, often results in cholangitis, reintervention, and the clinical deteriorations. And many of these patients probably will not require not receive systemic treatment because general condition deteriorates. They progress so fast. Next one. I have a slide. Next one. Next one. Next one. Okay, so this was one of the, I think probably no, the previous one. Previous one. So this was a meta-analysis and efficacy and safety of endoscopic ERCP versus percutaneous PTBD for cholangiocarcinoma biliary obstruction. And essentially, if you see the message that says there was no statistically significant difference in successful biliary drainage rate between the ERCP versus PTBD for management of cholangiocarcinoma or biliary obstruction. And this, of course, probably I think one a decade ago, when Dr. Saluja from AIMS did a randomized control study between these two settings, and the infection rate was in that particular study were higher for the PTBD, but other than that, there were essentially no difference. So this is very, very important for the colleagues to know that I think these two methods are available, and depending upon the expertise at the center, or maybe that the patient where he or she is landing, there may be some bias towards ERCP versus PTBD. But essentially, for a successful, if the drainage has been done or this thing established, then we don't find any significant difference in the ultimate outcome. Vamsi, you work in a center which is probably mainly for the GI, this thing, gastro specialty, and mainly the GI cancer. If we talk about the oncology practice, so what is the preference, or you just go by this thing, the where the block is, or you maybe whether this is a gastro?
So again, sir, it depends entirely on the location and the
Yeah.
type. If it is a ampullary or a pancreatic, it's definitely through ERCP. If it is a hilar, then we look at the type hilar. If it's a type 4 hilar, you look at whether in fact, in many cases in type 4, you even have splayed RSD, so you can't even do an PTBD there. So you look at whether you're able to cannulate and then go with an MRCP and base it on that. Type 1, type 2, possibly still go with a ERCP only, but if it is type 3 or type 4, PTBD is better.
Okay, Dr. Sahu wants to say something. I think I saw something in the chat box.
No, sir. Same thing. As Vamsi told, I just wanted to tell. I found if there is a severe cholangitis already present, and you do a ERCP and then the stent, there's a sudden deterioration of the patient. That I have found it clinically. Vamsi and Viswas, if they have found it similar, because I found patient going to sepsis and
Yeah,
really going to
immediate
shock.
shock.
Let me ask you, probably maybe that anybody, Dr. Vijay or maybe Bivas, during your training and now, when you most of us are in the private sector now, they're still maybe in the government sector. So, how many times you have seen the patient after a successful biliary drainage was able to receive systemic treatment? I'm talking about the palliative setting.
Yeah, I mean, see, when we were training, I'm looking at 20 years ago, I think if somebody had biliary cancer, they were dying imminently. And I think things have changed in the recent past. We've got better, we've got more aggressive in our management. Our radiologists are more aggressive, our gastroenterologists are more aggressive, our patients are demanding more from us in terms of outcomes. So I think we are doing more interventions now than when we were doing when we were training. So there's no question about that. And with the advent of immunotherapy in combination with chemotherapy, we do try to do procedures to get patients bilirubin under control so that we can identify those small groups of patients who may be either HER2 positive or MR deficient, who may otherwise do well with newer therapies.
All right. Vamsi, I think you're training at previously at AIMS and that and TMH and now at AIG. What is the difference? If you have 100 such patients, how many of these patients will be able to go for systemic treatment?
So now in AIG, we would say around patients who are otherwise okay for treatment in the sense that they have reasonable performance status and all, around
No,
70 to
I'm just
80% would
a
go.
ballpark figure. I'm not
Yes,
asking
sir,
about
70 to
US at this
80%. 70 to 80%.
Yeah, at least
and the
two-thirds or
TMH,
more.
The
TMH.
TMH, to be very honest, we don't know, so because when I was training, we were not dealing with the GI malignancies in TMH so at that time. So I really don't know. A very honest answer.
So I would say I can talk about I think previous practice at AIMS and they say if these patients they come with the jaundice, deep jaundice, requiring some kind of the biliary drainage and this thing, I would say at least 60% of them would not go for systemic treatment.
Sir, is it different now in your private practice, sir?
Yes, that's what I was coming to.
Yeah.
So nowadays, if you see usually they come, I think obviously one of the problem is that all of you understand that the BTC patient they progress very fast,
Fast.
and the time taken for the different specialty registration to the diagnosis to the some other investigations, imaging, and this thing probably it may be much slower in some of the hospitals than in the private sector. So that probably is the one thing which probably I will realize. But other than that, probably performance status usually by the time they come to the clinic, GI cancer clinic or elsewhere, the performance status also goes down and it become difficult to treat those patients with the systemic chemotherapy. Anyway, that was beside the point. Can we go to the next one? So many of us have heard. So how many of you have seen that there may be, I think, sometime when all the solid cancer we will be treating with the ADCs and this thing. ADCs are coming in the different in a big way in the solid tumors. We have in the breast, we have in the lung, we have in the bladder, urinary bladder, and elsewhere. Now there's new data coming up that probably ADC may be useful in the biliary and hepatocellular also. Or so, any thought about this thing?
Already for HER2 positive, there are pan-tumor study on BTC for trastuzumab or deruxtecan,
Yes.
and we know it's a good active. So that is there other than the usual anti-HER2 and chemotherapy and target therapy.
Yeah, so basically, I think so. This is the something which is coming. So I always used to say that the BTC are lagging behind, but probably it looks like they're slowly catching up.
Yeah.
The beauty of this thing is that probably there are many so BTs nowadays. More and more targets are being detected, and they are agents and this thing. So again, we'll be getting this thing. And for HER2, for sure, now we have a data from. I think I'll be discussing one of the abstract TDM one at least from the Vikas Oswal, but I'm sure soon we'll be having the ADCs also in the this thing. Personally, I have used, has anybody used ADC in the this thing? Biliary tract malignancy?
No, I've got no
Not yet.
Second, I
Sir,
think
we have
many people use, I have
Edna
used,
too.
but what is your experience? I just would like to hear the experience of the deruxtecan that is not for part of this no abstract, but still I would like to have some opinion about deruxtecan in the BTC.
So I have used for two patients in second line.
Mhm.
One patient is now on the third dose due for scan. The second patient, interestingly, the CA 19.9 did not change at all. There was a slight reduction in terms of size in the scan. Patients felt symptomatically better. So I would call it a stable disease.
So what dose you have used? 5.4.
I gave for that patient around flat dose of 300 milligrams.
300. Yeah.
I didn't give a full dose of 5.4 or 6.2 like gastric, but this was 300 milligram flat dose.
Dr. Sahu, have you used this thing, deruxtecan?
Sir, not in this setting.
Okay, you didn't get it. All right, next one. So obviously, this is something which is probably we'll be hearing more in the coming years and this in coming meetings, because as you know that about 15% of at least GBC in our setting, 15 to 20 will be having HER2 positivity, and in case these patients, the drugs are available, they progress more and more people will be using outside the clinical trial. And maybe that some VMC you are collecting real world data, so maybe that I have 2 or 3 patients, somebody maybe that around 20, 15, 20 patients can be collected data for 20, 15, 20, and maybe let us see how they have been doing or how did they do that. Next one. So this is something probably obviously, so obviously dextecan is most of the clinical solid tumors, and these are the old publication. Next. So these are few of the this thing ADCs in the clinical practice, BTC, which probably will be, and the targets are going to be HER2, EGFR, H4, MET, and TROP2. And these are the probably bill or top one, and the MMA and DM1. So be obviously you'll be hearing more about these molecules, clinical studies, and this thing clinical practice also. Maybe that one of the study does. So one of my colleague has used SG also. Has anybody experience with the SG in this kind of setting? That was based on the molecular report TROP2.
Never had this
No,
report
sir.
nor this drug in this setting.
Okay, next one. So we move
So
on to
TROP2 will be
next.
IHC, right?
Sorry?
TROP2 will be the immunohistochemistry you are talking about.
Yeah. No, this was I think NGS.
Okay.
Next one exam. So we can go. These are the initial data and this thing. So anyway, before that, can we also? So there was a study reported by Dr. Vikas was published last year in this thing JAMA
Great.
Oncology about their called GB adjuvant chemoradiation versus Gemcis versus chemoradiation using capecitabine before and after chemotherapy. So my question to all of you is, what is your practice with regard to the adjuvant treatment and basis for that? We may start with the Bivas, then Dr. Vijay Agarwal and Pamsi, and in case Dr. Sahu wants to pitch in.
As of now, we are mostly using either GMCs or for patient who cannot tolerate only capecitabine in adjuvant setting.
And Bivas, really, this thing want to know the basis for these kind of the practices, basically.
I think, sir, I'm not sure. The data was mostly for capecitabine, but in a like node positive patient, young patient, we sometimes do use well, compelled to use GMCs because knowing that it is a bad disease. I'm not sure about the data.
Dr. Sahu, so you must have dissected that particular paper, Bill Cap study, and then the
Yeah.
Prodige also. What is your
Sir,
opinion?
I think the best evidence, all said and done, has come from Bill Cap, and with his criticism, T2 and more, I always go for adjuvant treatment, and I advise capecitabine. But I feel, looking at my experience for metastatic and seeing what it is, popularly have gone for Gemcis. Although I agree that the data is more, and as per, if you are strictly from a science sense, it should be capped. But I feel most of my patients have gone for a platinum with them, and it is for me the cutoff is T2 and beyond. Node positive, sure, but the T is very important here, and T2 is something I will always go for a treatment.
Excellent. Dr. Vamsi?
Sir, the negative trial of Gemsys is there. The SWOG was negative, so I don't use Gemsys nowadays so much, except if it's a very node positive, multiple nodes, then somehow we tend to use it just because we have a faith, if there's no data for it. We have started using S1 more now, at least for the cholangios, and that seems to be better.
All right, so let me probably maybe the younger colleagues. So their main first, so first study for the adjuvant BTC was from the Japan using mitomycin, and they have shown that it improves the outcome. That was, I think, probably early 2000 in this thing. Ever since then the probably lot there was lull for many years until the Bill Cap and the same year almost the Prodige, probably these two trials were reported. My take on Bill Cap and Prodige is that both of these are the negative trial. If you look for the intent to treat analysis, then obviously these are the Bill Cap is not a positive study. If you see the per protocol analysis, then probably it may be considered. I think difference was just for a couple of few patients in this thing. That is one thing. The second thing is that only positive study which has convincingly proven that the adjuvant chemotherapy works was the Japanese study using the S1 JCOT study, which was published, I think, about 2 years ago in this thing. So really, if you see the data about this thing, then the strong data is mainly for the S1, and that's what I also use in case I don't want to use the GEMOX or GEMSIS. And Bilcap, usually the capecitabine, I prefer not to use it. So this was the study we presented probably. And so anybody would like to comment upon the Dr. Vikas Otswal's paper published about a year ago, last year in the JAMA Oncology?
You're talking about the radiation one, sir?
Yeah,
The
I'm talking about the radiation.
So again, it was an interesting study, but it was a phase 2, which was designed to go on to a phase 3.
Correct.
So the design itself was something where it was more of a preliminary study, and that proved it, and that did its job. So I think that's all I can say about the study. Until we get to the phase 3, I don't think I'm going to comment much on that.
Okay. Anybody else? What is the practice of using radiation in the BTC, this thing, adjuvant setting?
So for BTC, if there is a margin positive, obviously we're using. For cholangio, still we are somehow using in a few cases which are very node positive or not anything, but generally we are not using. As of now, we are not using. Routinely, we are not using.
And Dr. Bivas, Dr. Vijay Agrawal, or Dr.
Yes,
Sahu?
sir. Mostly for the margin positive revision, further revision cannot be done after completion surgery. As of now,
And
those are.
probably with for the node positive disease also.
Sometimes in heavy, but there's not a heterogeneous, not a homogeneous decision, not for all.
All right. So this was the study which we designed probably since. So let me give the background. Basically, we have been using some kind of the chemotherapy in the initial late 90s, early 2000. We were using 5-FU-folinic acid, something similar to McDonald's protocol,
Weekly.
and probably yeah, and in between sandwich radiation, mainly for the patients who had node positive or or R1 microscopic disease. Based on subsequently we move on to the gemcitabine based chemotherapy. That was the basis for designing this thing. Sometime we would use node positive disease radiation also. There was no obviously one policy. Time with the change of time we decided we probably change our practice. So this was the study I wanted to do for a long time, but unfortunately with this time also, though we were a little more optimistic that we'll be able to complete the study. Out of the 200 patients, we were able to accrue only 93 patients. We have to cut short, probably stop the study partly because of the COVID, partly because we were not getting the sample. So this was the study. I thought that will answer whether chemoradiation is useful or not. So next one, please. Next one. We have already discussed this thing. So next one. So we thought that the primary endpoint we kept is relapse-free survival. Next one. So I probably just spent 2 minutes on this thing. So this was the study design basically. So standard we thought that we'll be using chemotherapy alone, 6 cycle of gemcitabine oxaliplatin or gemcitabine cisplatin. This was a multicentric, so both combinations were allowed. And the second arm was experimental or three cycles chemotherapy followed by chemoradiation. This dose of radiation, we took it from McDonald's 45 GY in 25 fraction, capecitabine with the concurrent capecitabine, further 2 or 3 cycle, and boost was planned for in case there was a positive margin. Next one. So basically, next one. We can move on to the next. So we screened about 137 and were able to randomize 93. There was some imbalance with the previous one, please. So there was some imbalance with regard to the baseline bilirubin level in the probably more number of patients at the high bilirubin. Next one, toxicity, nothing great. All grade 3 and 4 diarrhea was more in the chemo alone because they receive most of these patients receive 6 cycles, where the chemo radiation arm they were either the 5.5, or 4 cycles. As expected with the exoliplatin being higher dose, probably more number of patients had the neuropathy. Next one. Next we can move on to the I think result section only. Yeah. Next one. So these are pretty. I think most of patient the follow up is strong. Previous one, survival primary endpoint. So if you see the probably when we designed calculated sample size, I thought that our previous analysis suggested relapse-free survival of 18. We thought that maybe that this was with the use of addition of the chemo radiation, it will improve to 28 months, and that was the basis for sample size calculation. Unfortunately, when we analyzed the data on 93 patients, there was no significant difference between these two arms, sample being the smaller. But on the contrary, probably the patient who just had the chemotherapy alone, they had numerically higher median RFS not reached versus to the about 50 months for this thing. 34 months for the patient who had chemo radiation. So I don't want to say that whether chemotherapy radiation was the detrimental, but I probably would say that there was no significant improvement by using chemo radiation. Next one. So these are the few of the prognostic factors, probably low albumin, node positivity, and the stage 3 or higher basically. And one of the important prognostic factor which we found was that the CA 19.9 value at the time of enrollment. If this was more than normal, then definitely these patients did very poorly, as that ratio being 4.45 compared to the one for the patient who had normal. Next one. This is again based on, so we can skip next 2 3 slide and then we move on to this thing. Yeah. Next one. So this was, and I am willing, somebody wants to have a question and this thing, so I'm willing to answer that. Or
Sir, my question is this: mostly we see systemic relapses in GB and cholangio. So, I mean, the rationale behind adding a radiotherapy, is it really there? I mean, wouldn't it be just better to give more chemo or add an immuno or something of that rather than radiation?
so basically, if they are the node positive patient, they say that they probably will have higher chances, positive margin, and node positive, they will have higher chances of failing at the local regional site also. First, and like, but I agree that what you say, the systemic failure is more common. But for the patients who are node positive disease, that there are chances of failing at the local regional site also, and that was the this thing. And sometimes, many times, probably maybe 10-20% is this particular trial didn't have those many R1 margin positive disease. But R1 margin positive disease is not uncommon, and traditionally, most of the time, we have been taught that wherever there is a margin positive disease, we probably may consider radiation, post-op radiation. So that was the reason for this thing. But I agree, and there's some systematic reviews which suggest that radiation, when you add to the chemotherapy, particularly in the node positive disease, will improve the outcome. So these were the few points we thought that, and if I speak to many colleagues, so radiation people will be saying radiation should be given, medical oncology is just chemotherapy, and there's a group of the people saying a chemo radiation also. So these were the things we wanted to answer this question for once and all, but unfortunately that question still is open.
Sir, is there any difference in pattern of failure in these two
I did not check at the time
Yeah.
of this thing. This was the question we had that time also, but I'll look into that. We can go to the next one. So, how many of you have seen that probably the days will be not far away when we have some kind of the vaccine and cellular therapy for pancreatic biliary also? So there was some presentation, initial reports suggest that the advancing frontiers vaccine and cellular therapy innovation for liver and pancreatic biliary cancer. Is anybody practicing anyway, let me have the comment from the colleagues. I think Dr. Vijay Agarwal, we see that lot and lot of many solid cancer probably they are being considered for the cellular therapy.
Yeah, so I think the data does not currently exist for biliary tumors. I think some people have tried for gastric using Claudin. Some people are trying it for ovarian, but I haven't seen any data for pancreatic biliary.
Can we go to the next one? Next one. So these are the probably ongoing trials. Basically, if you really want to see this thing for the BTC also, mesothelin, EGFR, HER2 new. So obviously, maybe that since the progress is going very fast in this field, maybe that in next 1 to 2 years we will be having more data and lot of studies for the cellular therapy in hepatic pancreatobiliary tumors. So we next one, I think there was some initial presentation. So no, that was it. So I think that is one of the highlight. Probably a lot of discussion was going about the cellular therapy in BTC, the tumors where we don't have the significant response to the chemotherapy, and that's it. Would like to have comment from the this thing comment regarding the patient reported outcome and supportive oncology in pancreatic biliary cancer. How many of us believe involving the palliative care training from the day one in the biliary tract cancer?
It should be, sir. It should be. These are very aggressive, advanced stage cancer, lot of morbidity. So yes, the like in many cancer, this at least the palliative care should be integrated from the day one in advanced stages.
And when
In
we
candidate.
talk about this thing, so the problem is that whenever you say the palliative care, so patient feels that nothing is going to happen. So when you say
So,
palliative care, what do you mean by palliative
so
care?
what do we do, sir? We start the therapy, then from second cycle when the, or third cycle when the patient start feeling better, we start referral to the palliative care physician just for, we say, start with pain control, appetite control, sleep improvement. These are the things we ask the patient to, we give some medicine and we also start send the patient to visit the palliative care physician. So we almost most of the we coincide the same day. Patients comes for chemotherapy, visit us after or before chemotherapy. They also once visit to the palliative care physician and they discuss about their symptomatic improvement. They do help, especially as I said, these are the aggressive cancer. When the patient progress, the transition, it helps.
Dr. Vijay Agarwal?
Yeah, I mean, ideally, I think palliative care consultants should get involved because
So
most
do
of these
you?
patients.
So do you
uh,
request your, or involve these
I
palliative?
don't have an in-house palliative care consultant, so I do it myself.
Oh,
Whatever we can do, it's one of those things. So I think if the if access to facility is there, ideally they should be involved. Yes.
all right. So they were this thing. Can we go to the next slide, please? So basically, and obviously, I many times do not give much of the credence or much importance to the PROs and this thing, but this PRO thing is probably has been going for about 1 decade, and the thing this is coming lot and lot people are talking about the patient reported outcome, and this probably has been seen that these kind of the services and referrals should be, I think, directed, should be given importance. Lot and lot of patients have this thing which sometime in the busy clinic we may or may not be giving or heed to this, but this was one of the one of the paper where they said the patient with the cancer, then probably patient report symptom assessment should be done. This can be used for the research purpose. They report to the clinical team or integrated into medical records so that inform the toxicity, this thing utilized to inform toxicity grading and so on. Next one. There are a few of this. We can skip this thing and then a few of the presented. So this was the, I think, so I didn't get the poster for previous one, please. Previous one. So this was the, I think I requested Dr. Vikas to share the poster also, but somehow other this was also not there. I think whatever I wanted to have wasn't full poster. So this they have been using. I think this is the presentation for Tata Memorial Hospital. This was supported by I believe the JIDUS TAP3 trial. So and they have used this thing TDM1 as a second line treatment for patient with HER2 positive advanced biliary tract cancer, and these patient has previous systemic chemotherapy and received TDM1 at a dose of 3.6 milligram per kilogram every 3 weeks until disease progression of this thing. But unfortunately, so it's when they compared the disease-free survival or PFS for these patients, it wasn't very different from their historical control. Any comment, Dr. Vijay Agarwal?
This patient must have received trastuzumab.
Yes,
Yeah,
I believe so.
right.
Yeah.
We're seeing more and more where TDM1 itself is not very effective, but we start giving Enhertu, we start seeing responses in this group of patients. So I don't think so. We use TDM1 anymore outside of breast, really, with Enhertu coming in and taking over the
Yes.
management of most of these patients.
Dr. Vamsi?
The TDM1 per se doesn't work very great in many places, is what we are realizing slowly. It
Mm-hmm.
worked a bit in breast, but that's about it.
Yes.
Failed in stomach. It failed in stomach. It doesn't
Mm-hmm.
work elsewhere. So I think that's kind of expected. And again, like Bivas was asking, whether to use it in first line itself, trastuzumab, we are still running on. I personally feel either the Enhertu or else the Zanidatamab, something like that will come into the first line rather than an ADC will come rather than only a pure TDM1 or a trastuzumab. That's my feeling.
All right. Next one. All right. So this was something I think probably we have been discussing, but this is the real life data from a multi-center study using this is a European study using capecitabine resected gallbladder BTC patients. I just probably come to the conclusion of this particular poster. Adjuvant capecitabine appears to increase DFS without statistically significant impact on overall survival in patients undergoing surgery for BTC. So this was something probably. So OS was 43%, almost same OS in the this thing capecitabine and surveillance group. But honestly, like Dr. Sahu was saying, so for the T1, PT1 or node negative, I personally don't use this thing, adjuvant capecitabine or any other agent. We don't suggest adjuvant treatment. But for T2 onwards, obviously, I do recommend. So I wanted to have opinion from you people whether for the PT1, I think the guidelines do say that probably for T1 also, they all patients, just like the pancreatic cancer, may be offered adjuvant chemotherapy.
So I think there is a distinction there between T1A and T1B, and I tend to use T1B onwards when there's a muscle invasion involved.
Dr. Biva,
Not much experience with T1 disease, so
MC,
not.
you have a large experience.
Pancreas, actually, to be honest, wherever it is operated, we are using treatment. If it is T1, we would probably just use S1 or we would use S1 only in the biliary tract. As per
But for
that.
PT1, you will be using adjuvant treatment?
T1. T1B onwards, yes. T1B onwards, yes. A, no, but T1B onwards, yes.
So guidelines probably and up to date also differs. Guidelines are different, up to date and recommendation are different. But I personally use for the beyond T2, whether T2A or T2B or any node positive. Next one. Again, this was something I think very interesting. I think real world impact of match targeted therapy on survival in advanced biliary tract cancer. So this was between the Mayo Clinic and one of the Japanese center, NCA Japan, and they say that the patient who received basically had some actionable mutation and received treatment. I don't think that if you see the table and the heading, the match. So the patients who had and the graph, patient who had actionable mutation and they received something, the drug which is directed against that mutation, their survival was much superior to the patient who had some actionable mutation but did not receive a targeted agent. So this was something probably I learned. So wherever this thing this thing actionable mutation molecular report because nowadays we are sending more and more NGS, and they have done the NGS through either the Caries or the Tempus, Guardant, and or Foundation. This seems to be, I think, something probably which probably to be kept into mind and clinical practice. We should be, I think, adapting these whenever we find a mutation. But the bigger problem,
Access.
पैसे and पैसे का खेल है. That's what this thing.
So bigger problem is access to those medication than few.
Yeah.
Very interesting that 11% had BRCA mutation, somatic.
Yes.
That's very
Yes.
interesting. There's
Yeah.
something I'm not seeing much. I have not seen BRCA. It's very interesting that they got 11% BRCA. Sir, any more? Sir, actually, you're just a bit short on time, sir. If you have any specific slides you would
No,
like
so
to share.
last one or two probably we can stop it any time.
Sir.
Last two is about the ctDNA and cfDNA basically. So we can go. There's another slide also. We quickly go into that. Oh, that was the last one. So any comment about this thing, ctDNA monitoring or this thing? Is someone doing this thing? We
No,
can
Sir,
go
not
back.
for BTC. Not for BTC as of now. The challenge again is becoming it is running ahead of any data. So we are having Indian labs which are doing CTC or things which I don't know what they
ctDNA.
mean at all. So right now, I don't think we should do.
All right. Anybody else want to make a small comment, brief comment?
I think more and more NGS is definitely required to identify those mutation. We are doing few of them. We are getting, but as I said, sir, most of these drugs is not beyond our reach so far. But at least things will improve, and
But
we have a
ctDNA no one is doing. That's what I wanted to know.
PTBDNS are doing in few of the cases we have done.
Oh, you are doing it?
So
Yes, sir.
ctDNA for monitoring, Dr. Bivas,
No,
not
sorry,
for
city. No, no, no.
changing.
Sorry. Not for monitoring. Not for monitoring any cancer, sir. Other than I think colon, we don't have any data for any solid tumor.
All right, thank you very much. So probably I think with regard to the BTC, except probably some hypothesis generating data and this thing, probably we didn't have much in this ASCO GI. Thank you, Vamsi, and thank you, Dr. Bivas, Dr. Vijay
Yes,
Agarwal,
sir.
Dr. Sahu.
Thank you, sir.
Thank you, sir. So thank you, everyone. Thanks for all the panelists. We now move on to a sponsored session by Dr. Rajesh Bullam on myths of immunotherapy. So, Dr. Rajesh, this is a session sponsored by Roche. So, over to you, Dr. Rajesh.
I'll try covering those 10 minutes what we have bracket in the last extended 10 minutes. Can you have the slides presented, please? Is the right question? Is there a myth? Probably the answer is no. Technically, these slides are given by Roche, and 90% of the facts we must have heard more than 100 times. So I'll try skipping the slides, which doesn't make huge difference. So we'll try to understand few facts. Next slide. Yeah, HCC is the third leading cause of cancer-related death worldwide. We know it. Next slide. So, technically, when we consider HCC treatment, uh, basically we consider it as we divide it as very early stage, that is stage 0, early stage, stage A, intermediate stage, stage B, and advanced stage, stage C, and terminal stage. Unfortunately, at least in my center, majority of the patients whom I see are referred to me if they are non-operable. And practically, if I see 10 patients, 7 to 8 would be uh, from the liver transplant guys, and majority of the times they would be in either advanced stage C or D. But for theoretical sake, if you see very early stage, that is single lesion less than 2 centimeter and preserved liver function, if they are potential candidate for liver transplant ablation, the then yes, if they are not potential candidate for transplant for any other reason, then we do an ablation. And the same is the case with early stage, that is single lesion or less than 3 nodules, each nodule less than 3 centimeter with a good performance status and a preserved liver function. If the liver transplant is feasible, we go ahead with the liver transplantation. If not, we go ahead with the transplant. In the intermediate stage, we do have got extended liver transplant criteria, that 3 centimeters have been extended to 5, and the AFP values. Again, we see here how is the performance status, whether the portal flow is preserved, yes or no, and there is an access, yes or no, whether there is any portal vein thrombosis, yes or not. Based on that, we do a local regional therapies, especially a taste when we have an access. And here today's discussion is more on a systemic treatment, concentrating more on atezolizumab and the new combination as well, wherein which if there is a extra hepatic spread or a portal vein invasion and preserved liver function with a PS1 or 2, then we consider systemic treatment. If it is a PS3 and above, majority of the times we ask for a BSc. But technically, though majority of the patients in clinical practice tend to come with PS3, still we attempt immunotherapy. Though guidelines say PS3 BSc. Next slide. Next slide. Abhimanyu, can you hear me? Hello. Yeah. Okay. Yeah. The BCLC 2022 incorporates new systemic therapy options. Uh, First line preferable choice is atezolizumab plus bevacizumab, or durvalumab plus trimitalumab. But majority of the times, I use atezobev because of first more advantage and experience of using it on more. There's no specific criteria that I don't use for durva or tremi, but having a little more hands-on experience with atezobev combination, my preferred drug of choice, if affordable, is always atezobev, until unless there is a contraindication or varices uncontrolled or any other comorbids for bev. My go-to regimen in all affordable patients is atezobev. If not feasible, then sorafenib, lenvatinib. Single agent durva I haven't used till now. And second line options post sorafenib or post previous immuno targeted combination. In general, if I've used a previous TKFS that is like a sorafenib, either it could be regorafenib if they are sorafenib tolerant but they had got a progression. If they are sorafenib intolerant and then had a progression, then I would use cabozantinib. The subset where I would prefer Ramu is if a AFP is more than 400. And the third line options we do have got is cabozantinib. If any of this is not feasible, a clinical trial is always an option as on paper. Next slide. So if you see the journey of treatment options from 2007 till where we are now in 2024, initially we have got sorafenib first line approval versus placebo based on the SHARP trial with a median OS of 10.7 months. Then from there, we had got in 2018 an approval for lenvatinib based on the reflect. After this trial, majority of the non-affordable patients for immunotherapy or by default have are using lenva. 10 out of almost 6 out of 10 of my patients usually will be on lenva. And in 2017, we do have got a data of regorafenib in second line versus placebo resource trial. Now, today's drug of choice for discussion is bevacizumab plus atezolizumab on first line versus sorafenib, that is Iambrave 150. The median OS of 19.2 months, which gave an excitement for majority of the medical oncologists, so that they can offer something in an unresectable HCC, otherwise, which is a detrimental disease per se. Next slide. Yeah, if you see the data of single agent PD-1 inhibitors, they have failed significantly to improve the survival against the sorafenib. If you see the graphs at 12 months and 2 years, hardly there is not much difference or gap in the curves, that is 33% versus 37 months. Even if you see the median overall survival, that is nivolumab versus sorafenib, hardly there is a month and a half difference. Hazard ratio being 0.85 and confidence interval crossing the unity. Next slide. If atezo plus bev significantly prolong the PFS compared to the atezolizumab monotherapy, if you see ZO31140 phase 1B study of in which 159 patients were randomized to atezo-bev, if you can see this is bev. Next slide. So if you see the complete response rates, if you see the objective response rate, which include both complete and partial, CR rates are of 8% with atezo-bev, and majority of them are partial responses, that is 20%. Stable disease is 44%, and if you see the disease control rate, it is almost 74%. And the duration of median duration of response is 18.1 months. This is something significant when compared to sorafenib. Next slide. The effectiveness data of atezolizumab plus bevacizumab from a AB real study. If you see the median follow-up, it is 10 months. Median treatment duration is 7.3. Grade 3 to grade 4 toxicities are around 23%, and adverse related events related to atezo is 20%, and bleeding events are 8%. In the real world evidence as well, the median OS was almost 16 months, which is almost close to our IM IMBRAVE 150, that is of 19 months. So even in the real world study also, we usually see 1.5 years PFS in our clinical practice. Next slide. We can slip this. Next slide. Next slide. Next. Next slide. So coming to the durvalumab and tremelimumab, the STRIDE regimen significantly improved OS when compared to the sorafenib. And later after this trial, we try comparing, do we have a specific place where in which we choose this? And if you are given a choice, how to compare both? Then we can end this. So if you see the overall survival, OS events and median OS, the median OS in the STRIDE trial is 16.4 versus 13.8 in sorafenib, and the hazard ratio being 0.78, and the median duration of follow-up is 33 months with this trial. But if you see, the curves maintain the gap uh, right starting from 18 months, that is 41%, 48. Median 18 months overall survival is 41%, 48. Whereas at 2 years it is 32% versus 40 months, and whereas at the end of 3 years it is 20 versus 13. So almost a 10% difference gap, and the gap continues. Next slide. Adverse events, if you see, more or less, stride and sorafenib. Any adverse event percentage, if you see, it's 97%. But more so, our interest of choice is serious adverse event and adverse event leading to discontinuation rates are 8% versus 11%. 11% in the sorafenib arm, 8% in the stride arm. Next slide. So technically, it is also well uh, uh, tolerated drug. If you coming to the third one, comparison of atezolizumab plus bevacizumab versus lenvatinib, because majority of the times now the trend is to hardly we see people using sorafenib. Majority of the times, if they are not affordable, our drug to go ahead is with lenva. So how does it fare well when compared to the lenva? Study period, if you see 7 years period, that is 2015 to 2022, with a choice of therapy left to the provider discretion of after both available treatment options. If you see the graph, definitely atezo-bev scores over the lenva. Next slide. If you see the network meta-analysis of the phase 3 trials, that is atezo-bev versus other, with respect to the most important endpoint, that is mortality. If you see the atezo-bev versus durva plus uh, tremelimumab, still the hazard ratio is 0.74, and though the magnitude of benefit, the delta magnitude difference is highest in AB versus sorafenib, AB versus lenvatinib plays the second, and AB versus durva plus termelinib. But in all these things, there is a trend towards A plus B regimen. Though in few of the trials, it is crossing the unity, but the delta difference is more if you are comparing with a weak comparator arm, that is sorafenib. For all practical purposes, we should keep comparing, at least in Indian practice, if they are not affordable for durva or tremelimumab, A, A plus B versus lenvatinib. This is what we usually counsel the options in our clinical practice. Next slide. And what does that INASL recommendations for the patients with advanced HCC? So whenever the patient is not fit for the liver transplant or any locally available therapies like LDT, liver directed therapies, the first line options we have got are 5 regimens. One is atezo-bev. Majority of the times it is the first preferred regimen with the strong data and long follow-up, provided if they are affordable. And the second, if they are not affordable, is a combination of atezo-bev. Uh, uh, it is lenvatinib majority of the times. The single agent durva and combination of durva or tremelimumab is little less used, at least in my practice. Coming to the second line option, the options available are based on the previous treatment options what we use. Suppose if the patient has progressed post atezo-bev, then the options available are either sorafenib, lenvatinib, cabozantinib, or regorafenib. That is, if they have got a combination of immuno plus VEGF inhibitors, it is a TKI. Other way around, if the patient has received the TKI, that is sorafenib or lenvatinib, then we have got another options like cabozantinib, regorafenib in both the arms, and whenever there is a AFP more than 400 subgroup, we can give ramucirumab. And the immunotherapy option is always used. Use an option whichever is not used prior. Then we have 3 options like atezo-bev, single agent pembro or nivo. If at all, if you had to use immuno or immuno plus targeted therapy, it is better to use immuno plus targeted if the patient can afford, as the numbers are not great. But however, nevertheless, if they are not affordable, using single agent immuno also is better, but try to use if it is a combination. Next slide. Screening for varices in the patients with prior to the systemic therapy. This is one of the important points. I think everybody knows it. Whenever you are planning to start any patient, any new patient on a atezo-bev, check an endoscopy and see if there are any varices or high risk of bleeding. If at all, if there is a high risk of GI bleed, it is better to treat the bleed potential varices and then start. Already existing bleed or a mild varices, then we can start them on beta blockers and then treat. Next slide. the management of varices is the optimal treatment for a large varices prior to Atizo plus Bev. Initiation is unknown, though AASLD recommends at least one session of banding. Carvedilol may be considered as an alternative management of varices prior to Atizo Bev. In our institute, at least we make it a point to make sure gastro team goes and does a scopy and gives a clearance for all patients of us prior to starting of Atizo Bev, especially under a background of CLD. Patients with recent GI bleed within 6 months and those with a high risk of stigmata for bleeding on EGD should have varices adequately treated prior to the Atizo plus Bev initiation, or these patients may be considered for Durva plus Termellar. Next slide. Uh, Next slide. I think we are running short of time. We'll try to skip it. Next slide. So the next 3 to 4 slides, the take home message is whenever there are varices in a patient whom you are using atezolizumab, try to screen for it is point 0.1. If there is already varices present, treat it before starting it. If it is a mild varices grade 1 you feel, use it a beta blocker. Can we use it in VP4 patients? Yes, we can use. Next slide. And having seen the efficacy, what about the quality of life? Yes, it has got.
Rajesh, could
Sir.
I ask you to just wind up? You're right out of time.
Yeah, sir. Skip. I'll just go to the conclusion slides and then we'll close it, sir. Next slide. Can it be used in elderly patients? Yes. So to summarize, there are notable advances in systemic therapies with the introduction of immune checkpoint inhibitors. Atezolizumab is the preferred first-line therapy option. Several studies highlight the benefit of multidisciplinary care, and everybody in the audience agree. Definitely, HCC is one place where MDT plays a huge role because majority of the times, what we feel is not operable sometimes as a Madong can be downgraded and then be given for taken up for the LDT. Liver directed therapy, and in LDT there are again many options: microwave ablation, taste, tear. So those all things has to be discussed in MDT. Thanks for your patient hearing. If you've got any questions, would be happy to take.
Thank you, Dr. Rajesh. I think I'll be addressing a few of these during my panel discussion, and if anybody wants, please type the questions. We will be happy to take it in the panel discussion as well. So I will just share the screen for the next part, which is going to be on sorry, I have shared the wrong slide. Just a second, please. So the next presentation will be a panel discussion on HCC, again with the reports from this ASCO. The panelist for this would be Dr. Bhuvan Chuk, who is doing a lot of work with HCC, and Dr. Sahu and Dr. Vivas, and Dr. Viraj has also joined. So I'll be very happy to have Dr. Viraj also for a few of the discussions. So I'll just share the slides now. Just a second. Right. I hope my slides are visible.
Yes.
They're seen? Okay. I'm just making it big screen. So, all right. So what I'll do is I'll straight away jump into the next 30 minutes. We will finish this. So the options of first line unresectable extrahepatic in India, we have Atezo-Bev, Durva-Tremi, which are available. EP-Nivo is not yet approved, but it is available. Tori-Bev has got a new application in China last year, and the data has come out. Camrelizumab, rivocertinib, again not available in India, but it is there. 2 negative trials. We have Atezo-Cabo and Pembrolizumab, which were negative. And of course, we have lenvatinib and sorafenib available in India as well. So let me go ahead with this paper, the Checkmate 9DW expanded analysis, Nivo-Ipi versus len or sorafenib as first-line therapy for unresectable hepatocellular carcinoma. Now, this was the panel, this was the model. 2-3 things to point out. Child PUG only 5 to 6, no VP4, ECOG PS 0 or 1. Nivo was 1 mg per kg, EP is 3 mg per kg. Remember, this is EP 3 mg 3 weekly for 4 cycles, not the standard treatment of EP1 that we are comfortable with. Nivo was 1 mg per kg, but then jumps to 480 mg Q4 weekly. So in a sense, in India, if you have a patient of 60 mg, you're going to give 60 mg to begin with, and then jump to 484 weekly. So this is the dosing. So the other is, of course, the fact that the investigator's choice was either len or sorafenib, right? So let me just ask first the Dr. Bhuvan, how common are these patients for us? Child poke 01, 5-6, ECOG 01, no VP4. How common are these patients, Dr. Bhuvan?
So I think I would not say, I would say they are not uncommon. Possibly what we're talking about is A5, A6, some are B7, which generally, if you manage the CLD well, they get converted to A6. So I'll not say that the proportion is merely small. I think it does represent a fair number of patients who are there in the clinic. I would generally extend B7 to this because, as I've told you, that reversibility to A6 is something which is potentially possible in them.
Okay.
And yes, VP4 definitely something which has been excluded, and that's a bummer. But yes, there are patients who are VP3 also which are there.
Okay. So, Dr. Bivas, in your practice, how much would fit into this? In my practice, it would be around 50% would fit here.
Maybe 1/3 maximum. We
1/3
don't see.
Okay. Viraj, are you there? Dr. Viraj?
Yes.
So in your practice, how many percentage would fit into this sort of a clinical trial?
So yeah, I would agree with you about half of our advanced HCCs would fit.
Half, yeah. So that's one thing which is interesting because all the clinical trials, with the exception of IM Brave, have excluded main portal vein and also have excluded large liver involvement of more than 50%. So that is something we need to remember when we are talking about this. Remember, the checkmate also looked at around 30% each of HBV, HCV, as well as non-liver, which is kind of what we have been seeing in all the different trials. So again, comparator arm has been sorafenib everywhere, but in this arm, it was lenvatinib. So Dr. Bhuvan, are you happy with the comparator arm of sorafenib? Because as the previous speaker was saying, mostly we use either lenvatinib nowadays. So is this
So
trial
definitely not. I don't think any of us are using sorafenib anymore. I mean, in this trial, I think 85% were lenvatinib
correct?
and
Correct.
15% were sorafenib. So I think it's fairly. I think this is a fairly well done trial when it came to it.
All
Yes.
right. So is this a better alternative trial? Because remember, the others have compared to sorafenib. None have compared head-to-head immuno. This is the only one which is comparing to lenvatinib, other than the LEAP, which was a negative study.
I definitely agree. I think that's the
Okay.
standard arm it should be. I don't think sorafenib. I am not comfortable using. I don't think I've used it for past 3 years, at least 3 to 4 years since the time
So,
Lenvan
Bivas,
test.
your thought?
Mostly we are using lenvatinib. I think over the last 2-3 years when the lenva generic came. So I don't think anyone also using sorafenib.
So incidentally, today I saw a patient who has come from Guwahati who has been put on sorafenib 400 mg BD. So, it is still used. So
Right.
I will not say it is not used. I was also very taken aback because I've seen this after a very long time. Viraj?
I agree. Lenvatinib, if not immunotherapy.
Lenvatinib, if not immunotherapy. Dr. Sahu?
Okay, why are we so harsh to sorafenib? What is wrong if someone uses
Because
it?
it's a harsh drug.
Let me complete first. So if you look at it with the dose reductions, still it has done in every oncological outcomes equivalent except for response rates. So that is one, if I'm not wrong, Reflect is the trial we all quote. What is wrong? And in giving a sorafenib, because I would, if I'm looking at response rate only as the criteria in my trial, then I'll be little skeptical. But if my oncological outcome of OS and the other oncological are endpoints, what is wrong in sorafenib versus lenvatinib? Can anyone in the panel explain it to me in a scientific
Can
way?
I answer
Yeah,
that?
please.
Yes, Bhuvan.
So, even when you start lenvatinib for a patient of CLD, the basic problem of nutritional intake goes down. So lenvatinib also is associated with lack of appetite. There is a fatigue, and then there is some bit of mucositis, and this is with lenvatinib. Sorafenib just causes that at a certainly higher degree. So if you look at a patient who comes to you with a A5, A6 or a B7 and you tell them to take sorafenib and the appetite goes down and then your muscle mass anyway is very low. So at the end of a month, you're looking at a totally debilitated patient who has not eaten and there is a lot of mucositis. And that is what the basic problem with sorafenib is.
Can I
That's my point.
Ask one thing to
can I
Dr.
come
Sahu?
into? My
Can
question
I
was
add
very
one thing?
different.
No, Dr. Sahu, Reflect showed a PFS of doubling with the lenvatinib, 7.2 versus 3.6. I agree there was no OS advantage in that. Every trial of IO versus sorafenib, the PFS of sorafenib has been around 3 months. The OS has been around 14 to 15 months. With lenvatinib, comparator arms has been around 5 to 6 months PFS. And also the POS has been around anywhere between 18 to 20 months with lenvatinib. So I think that's the right answer. There won't be again a study of lenvatinib versus sorafenib, but this is the
If you
comparator
look
arm.
at the recent, I'm not supporting sorafenib. If you look at the recent trials, even in the sorafenib control arm, the OS is increased because of the users
IO.
post progression.
Correct.
So if you look at even the nivolumab data set, the OS would be every OS in the recent trials are touching 16 to 18 months, even in sorafenib.
So
अच्छा,
again,
जब इंसान खा ही नहीं पाएगा तो
Dr. Bhuvan, I think so.
मतलब
Dr. Sahu, it is not an easy drug to handle for all of us.
Yeah, exactly. I'm not telling I give sorafenib.
Yes, it is not an easy drug to
I'm
handle.
not telling I give sorafenib. I give lenvatinib. So point is, as an oncological outcome in a trial setting, I don't think it's a bad idea.
Okay,
My
fine.
point, small point.
Right. Going back to the Nivo EP study, Dr. Bivas, this is a crossover and we have had plenty of discussions on the crossover
Yes.
study. And remember, the overall survival here is 3 months advantage, 0.79, just touching your, close to unity. So it's 0.79, it's not 0.6, 0.65, which we like. It's 0.79, which is very close to 0.8. So how significant is this OS that you're getting here? And the crossover, do you think it matters?
Yeah. So if we calculate the area under curve in the Kaplan-Meier curve after this crossover, not much of difference, as I say. Even the delta in the later part is also not that great. So yeah, clinically not major difference, if you ask me.
Viraj, Nivo EP, 23 months. This is the longest we have seen for any trial. Is it just that because it's a later trial we are seeing 23 months? Or is it just that it is really what it is doing?
No, I do agree that there is a merit to dual IO use in HCC. But I do agree that it's only limited to some people. I would say about half of patients don't do well. And that's where the curves are crossing. And if you show the later slides, we know that if they do well at 6 months, these are the patients they really do well on IO. And if they don't do well at your first or second scan, probably these are not IO-driven tumors. So I definitely think there is a merit to this. And I would definitely use IO in HCC because it's a common phenomenon. Any trial you see, if at 3 months or 6 months they're doing well, you then see a tail. While if you see it on Lenva, there is no tail.
So the hazard ratio for CR or PR versus progressive disease is around 0.14. A slightly weird way to assess because if you're progressing, that means you're doing bad. But important to look at these curves. The top is where the CR and the PR are. And that is what Viraj was telling, that if you're doing well, if you are in that group which gets a CR or a PR, you're likely to continue on it for a long time. And I think that's true for all immunotherapies in HCC, at least that we are aware of. So again, an important point that if you're doing well, you'll do well. If you do badly, you do very badly. So Bhuvan, your thoughts on that?
So I do agree. I think unlike what you generally see in immunotherapy, in which you see that the a long-term response or a delayed response is what is seen, but in HCC it is pretty clear that by the end of 3 months you get an idea whether it is going in the right direction or not.
I think in the end
that
of
is one, and I think
in the end of 3 cycles, you will realize what is
end of 3 cycles you will know whether you are hitting the right direction or not. But I think my bigger issue with this will be, I don't know about the EP toxicity. I've not tried it. With 3 milligram per kg, somebody who has a OTPT of somewhere around 80, 85, and in that range when it is 2 times the upper limit of normal, when I give them the 3 milligram EP, how will they react? So I think that's my hold back to it. That's all.
I think that's something
I have a very strange thought here. There are at least 5 data sets, one from India as well, many from India actually, with low dose immunotherapy. If we look in detail, Lowering the dose of immunotherapy has not reduced immune-related toxicities. It's a food of thought. So I don't think 3 mg versus 1 mg, it's just in here. Uh, all the low dose studies that we have currently from Brazil, India, wherever, the immune toxicity is identical as you would see with full dose.
In that way, the flip it and the effect should be also be identical.
And
Correct.
it
Then
is,
why do I need?
and that's
Then
why
why
it
do I need
is.
to?
That is exactly what Viraj is hinting at very diplomatically and not saying give low dose. I have used low dose in a couple of patients in HCC. I personally don't advocate it. And I don't think in GI, other than the MSI high group, we are
It
finding that
works.
low dose works. This is my personal view, but again, we can debate this till the
Vamsi, a
cows come
small
home.
point.
Yes.
To all said, that has been said, I agree. Can you go back one slide?
Go back one slide. Yeah, one
Yeah,
second.
the curves, the
Yes.
Kaplan is
Yes.
something we want to look at. The intent to treat
Yes.
population.
Yes.
Yeah. So this is a typical thing of where we should be asking questions to the authors to release the RMST curves, the data.
Right.
Because if you look at it, you have around 20-30% of the time period of the curve where actually the study arm is doing worse than the control arm. And it is something like 5 to 2, but 5 to 2 the difference was for breast cancer is that only 15% or 20% of time the curve was down, and then the curve separates. So point number one, what Viraj told, if you respond, but problem is that the curves are separating at a much later point, at around beyond a month, beyond a year.
Correct.
12
So here,
months.
if the
Correct.
RMST would have been also put forward, you would have got a real idea of the benefit. But
Correct.
the point which I take is the second half of it, that the response which we have spoken about. If you look at it, the delta is just increasing with every passing 6 to 8 months. So that's what Viraj spoke. The second take home for me is patients, irrespective of what they do, once they start having a CR, even in Lenva, the curves, the statistically, it's a significant versus a progression that all of us expected. So these are two take home for me. So this I did not see in any HCC curve this late separation, and the curves really only cross each other at 12 months. It's a huge time period. You're losing a lot of patients by the time.
So the other interesting thing for those who like watching statistics is this, where you have a upper limit is only 40, not 100, which should ideally be. That's why this curve, these look so different.
Yeah.
Just
They
picked
just
up on
magnified the effect. That's
The height.
yes, the heights. Correct. So that's about this trick. Remember, the toxicity in it was again acceptable, is what the author said. The best overall response group for if you go by subset. Now, this is something we keep discussing with every IOT study, and I highlighted it here. There is no difference between the HCV and the non-viral. HBV also, it works, though the range is a little wide. So this is one more IO. So this is what Viraj was saying. IO, probably your Durva-Trimi showed this, your Nivo-IP showing that if you use IO, your etiology may not matter as much. And I'll come back to this later a bit. This is the safety related, and now obviously the grade 3 and 4 are higher in the Nivo-EP study, which is kind of expected. And when you looked at the hepatobiliary disorder, it was 11% here, grade 3 and grade 4 versus 3% with lenvatinib. So, this is something which we treat. Bhuvan was saying, you start with a patient and the patient just crashes with the hepatobiliary. It is something that you really, really get worried about. So I think, Bhuvan, this is the hepatotoxicity that you were talking about.
Scared about it. And most of these patients, they also have a BCLC-B. At times, you're starting with a BCLC-B and you're fighting with the surgeon to not do LDT or a liver-directed therapy. And then when you lose the patient to this, it becomes a bummer, basically. Is what
I never started in BCLC-B. I'm too scared of starting anything in BCLC B8. B7, I still go ahead. B8, it's a no-go, no-fly zone for me. So this study actually demonstrated a significant and meaningful OS benefit. As we have all been discussing, is it meaningful or not? We don't really know. It's a new standard as per the author. So we have 4-year overall survival data from Himalaya. We have the LEAP. We have the already our paper from the Etizobev. So all of these, when you combine, now this was the other paper which came last year, camrelizumab plus rivorutinib. Rivosaranib is a oral anti-VEGF. Camrelizumab is a PD-1 inhibitor. And there again versus sorafenib. Look at the OS. You have again 23.8 months with this combination. Sorafenib only 15 months. Whereas when you look at the PFS, again 5.6 versus 3.7. So again, look at this hazard ratio. We are not likely to get rivoceranab. We might get camrelizumab. So again, Viraj, IO plus PEF versus IO. Where do you stand? IO plus an anti-VEGF, sorry.
Yeah. So IO-VEGF remains a go-to regimen for me in my practice for viral etiologies. And for NASH, I tend to offer IO if they can afford Imjudo, which is very expensive. But we still end up using atezolizumab. But I believe, and since couple of years we've been discussing this, that it's the NASH where IO plus VEGF falls off little bit, and that CTLA takes over in the NASH etiology. Although these are all retrospective, but this is what I have made up my mind as of today.
Can I ask something? Tomorrow, if the nivolumab arm in this study comes out to be, there's a nivolumab arm, ma'am, for the last study.
No, I don't think so. This
And
did
there was
not.
a third arm.
I think it was only 2 arms as far as I am aware. I'm not sure there's a third arm, because third arm is.
And for the IM Brave,
Yeah.
it was not powered to answer the viral, non-viral. And
No, none
so
of them
it
are
was not.
powered. None of them.
That's why I said initial post hoc, but in Himalaya and Nivo EP they were
Yeah.
stratified.
So these were the two trials powered to answer this question, and they both showed that it does not matter. And if you look at the
No, so that it means that IO works in NASH, while all other post hoc analysis said IO does not work in NASH.
I will send you one more bigger analysis which has shown that okay. But my point is, are we just looking at post hoc in some trials to our benefit?
Okay.
And
So,
sometimes we
Dr.
criticize
Sahu,
it.
can I answer this 2 minutes later, because I'll be doing that.
Okay, you have this. Okay.
I have that data which you are talking of. So this is the comparator arms, atezobev versus durvalumab. Let's keep that. The cabo atezo, we have the data which had a PFS advantage, no OS advantage. Pembrolizumab, no OS advantage. The durvalumab gave you an OS advantage of around 3 months. Atezobev around 5.5 months. But atezobev also gave you a PFS, also gave you better overall response rate, though again it is slightly weird because you have sorafenib doing so much better here. So these are the basic data. So based on that, Dr. Bhuvan, would you do like what Viraj is saying? Any contraindication to BEV, be happy to use a IO. Any non-viral, be happy to use a IO, and other places either is fine. Or as some people say, only when there's a contraindication to BEV, give IO. What's your take on this?
So just a minute before I go to that, I think that is the reason possibly when you add a VEGF, the initial drop which happens because of IO doesn't happen. It's basically if you are fearful that if you had a progression and the patient will totally crash, then doing a IO VEGF becomes an indication, or IO VEGF would be a choice there. But yes, obviously when you have a high grade varices, that is something you do IO. But then I think in today's world and era, most of these patients who have a intermediate varices, they're able to treat and give them IO VEGF if required. So for me, there is no real compelling reason for a IO unless you're looking at a post hoc analysis in which most of these NASH patients, there is some evidence. I do not have data as it, and I'm not saying I'm with Viraj when I say that there is no data, but inherently I believe that that IO VEGF does not work in a NASH. It has for me never worked, and hence the reason I'm looking for IO in NASH related. That's all.
Okay. Dr. Bivas, your take on this? Would you agree that IO is only when BEV is contraindicated, or you think both are equally good?
So
I'll listen to your answer and then I'll give you my opinion.
I don't have much experience of IO personally. I'm treating only for a recent time. But yes, I think mostly we see whether there is a bevacizumab contraindication, that is the first one. And for others, we use IO. But again, my experience is very poor. Mostly, I'm stick to lenvatinib.
Okay. So again, we have been using, and my personal view is, again, I'm kind of swinging towards where Viraj is going to. And this is an independent opinion. We have not really discussed this personally with each other. But similarly to him, I feel IO is as good as probably IO VEGF. You would tend to give more of IO if you are having a NAFLD or a NASH related thing. Wherever BEV is contraindicated, job becomes easy. Where BEV is not contraindicated, which one to use? Honestly, my own personal experience, if you have a bad liver for any reason, Atezobev does cause a lot of hepatotoxicity. My limited experience with IO has not shown that. I don't know what will happen when I use Nivo-EP in that scenario. So that's my take on that. So this is the first line Atezobev. Now, this was a real world evidence, Dr. Sahu. This was a real world evidence, first line Atezobev versus Durva-Tremi. Now, it's a real world, multi-institutional, retrospective cohort. So absolutely nothing you can take, with all the caveats that I have just said. It showed that the responses were equal. The OS was similar. Objective responses were similar. Time to treatment failure similar. Now, retrospective, but this just gives you some indication of where this is going. I'm sure you'll have data too, also the other way around. This is the subset that we keep talking about and we have been discussing. This is the paper which I think Dr. Sahu was talking about, the Nature paper. Now, this Nature paper showed that if you have NAFLD, it was median of 5.4 months, OS of 8.8, whereas other etiologies, it was much better. But there's a caveat. This included Checkmate 459 and Keynote 240, which were actually second-line studies. It included IMBRAVE. So these were second line, this was first line. It did not differentiate NAFLD versus alcoholic liver disease, which could be another 15-20%. So we don't know if that contributed. This study with present day, which includes Nivo-EP and includes Durva-Tremi, is not there. So this is the data. Dr. Sahu, was this the data that you were saying?
Yeah. And this is a propensity score matched study.
Correct. So again, this is the caveats here. I have not found.
This is the best evidence actually you have for people, and apart from the forest plot of Iron Brave 150.
Okay. So again, the idea is this paper, I'm just showing you the clinical part of it. There's a lot of preclinical things which they did, where they actually injected mice and they said that if there was NAFLD, there was actually a lymphopenia, there were T cells were depleted, therefore immunotherapy will not work. Now,
apart from that, Vamsi, there is one more paper which I was speaking of, which is the best evidence that was published in Annals of Oncology, and that was a match propensity score.
Sure. Understood.
Yeah.
So I just have a point. I think what we are missing here is, but we're also trying to elicit it is that a NASH liver is a very bad liver as compared to a viral liver.
Correct.
And I think that is where this entire thing is. So, if you look at the recent ASCO, basically what you're looking at is the healthy liver versus the health of the liver when you're giving IO or as IO, whenever you're doing a therapy. So a NASH liver who has presented to you with a cirrhosis and HCC versus a HBV liver which has presented you with HCC, for me, they're entirely two different set of patients in terms of the health of the liver. And I think that's the reason most of these patients, they tend to do worse, especially when you consider the NASH. So, it may be that this paper which Nature showed, the NASH would have done worse anyway because of the health of the liver. So irrespective of that, it is.
That is a possibility. This is a paper from last year's ESMO where they actually looked at the impact of viral etiology in phase 3 Himalaya study, and they found that in HBV it worked very well, non-viral it worked well, HCV it actually kind of did not work great. Now, whether that was the numbers, whether it is this, we don't know, but this is what the data was with regard to this thing. This is the updated IMBRAVE which Dr. Sahu was talking about, where the non-viral is actually exceeding the unity by 1.05. So this is the data from IMBRAVE, which is updated analysis. From India, we had actually a collaborative multicentric study. This was done by Anant. And interestingly, in this study, if patients were like the trial cohort, which means B6, A6, good PS, they had a significantly better OS as compared to non-trial patients. And they also found that those patients who had NASH, it did not really matter. The results were similar. So again, these are real-world studies with all the caveats of an Indian study, but this had around 150 patients. And this is something interesting that we could find. Right. So we have 5-10 minutes to go on intermediate stage now. We'll just try to finish it in 10 minutes. Anything else from any of the panelists regarding the upfront treatment? So Viraj or Dr. Sahu, anything else you want to share on first line? Or we'll move ahead to intermediate stage?
Nothing, but only just again looking at and looking across it, I think touching the data too much. The hepatitis C in Himalaya, that cohort somehow has not done as good as the B. I'm not telling this again, you as Sandil tells, torture the data and the data starts picking out. But there is a dichotomy in the amount of benefit.
Which honestly doesn't really matter, where HCV is really, really dropping. So far, that's what it is. HCV incidence is dropping, especially
So,
with the
does the panel differentiate C and B differently?
Correct. Which one?
The B and C, do they look at it differently when they choose a treatment?
I am not looking at it. Viraj?
Not to decide on treatment, but just we know HBVs, they're not necessarily serotics, and HCV almost always serotic.
Serotic.
So apart from that, nothing much.
Agreed. So this is the intermediate stage. Now, intermediate stage, this was the paper in this year's ASCO GI. TACE with camrelizumab and rivosaranib versus TACE alone. KS005 phase 2 study. Again, here they looked at patients who had undergone TACE. They could have allowed it. And they compared to TACE with the immuno and the anti-VEGF versus CTACE. And they found that patients included here were including VP4 and VP3. So, these are patients excluded from your BCLC-C studies of unresectable and untasteable, but they were actually included here, which was a bit of a surprise to me that how they could include it here. Again, all were child poke A and mostly HBV. Now, this is interesting because all the camrelizumab are coming from the China, where its HBV is very, very prevalent. They have hardly anything of HCV, hardly much of non-viral. This is similar to the earlier care study that I showed you. And PFS 10.8 versus 3.2, huge benefit. And when you look at OS, again, 24 to 21.5 months. Dr. Sahu, you have a scenario which is non-metastatic, and your median OS is 24. Your median OS with Nivo EP was 23.7 months in the previous study, So BCLC B, C, both do badly. That's the bottom line. Yeah. So this is something which I think all audience should understand. It's just because TACE can be done doesn't mean patients are going to do fantastically well. It's a matter of case selection as well. So Bhuvan, do you agree with this statement that we need to understand that not all BCLC Bs are the same?
I do, but I don't agree with this. As in, we're comparing two trials in which one included VP4 and which one didn't include VP4.
Correct.
So I think for me, this TACE was not the right done TACE, and the reflection of the data OS is not the right OS data.
Possible. I agree with you. But again, in practice, again, to bring in now to Dr. Bhavan, would you have a scenario where you prefer adding immuno after TACE? Are you starting to do that somewhere? Because this study showed some evidence for it. And the other studies, that was Emerald 1, which came actually last year, this also shows that there's a benefit of adding Durva with Bev in these patients who are otherwise eligible for embolization. Look at the PFS.
So I kind of do LEAP 012. I think for me,
LEAP 012. I am coming to LEAP 012.
I think it's
I'm coming to LEAP 012.
Yeah. So
okay.
As in essentially that basically what I'm saying is, so I agree with you. Post TACE something should be done unless you're looking at a very small lesion in which the TACE has cured. But then post TACE something should be done is what we are saying.
Dr. Viraj, D plus B is better than TACE. We know that. OS is not there, but PFS is there. Are you satisfied with that? Are you happy to go ahead with the D plus B?
No, so, just I wanted to make a comment on the earlier trial you showed. They were not truly Bs. If you see the...
yes, they were Cs. They were also Cs in that.
No. But even the Bs were not the true Bs. They were 80% beyond 7 criteria.
Correct.
Right? Which we in our practice would never subject them to TACE.
Fair enough.
And that's why that 3 months PFS of TACE, we would know that these are not the intermediates.
Absolutely.
Actually, they were giving TACE to, we would not. So that trial does not answer any question that we had. While these two, Emerald and the LEAP, and the surgery followed by atezo, I don't remember which one. So the question still remains whether the effect is additive or it's superaddictive. If you do one and then later at progression versus don't wait for progression, add it. I doubt whether there is OS because none of the 3 trials have showed OS benefit. And even if you see the OS of the previous study, which you showed, they were same. Despite having a huge difference in PFS, I assume that patients who progressed on standard TACE-arm were all offered immunotherapy and they were all rescued back again. And that's why you had OS of 21 there as well. So that answer is still not answered, whether this is additive or superadditive.
So Viraj, Emerald D plus B, yes or no?
I'm offering. If that's a question.
Perfect. I think we have to agree if there's a really bad disease, then yes, I would start offering. This is the LEAP. Now, LEAP again was similar, LEAP 012. That used Lenva Pembro, again PFS advantage, 6 months. OS, as of now, not there with the hazard ratio of 0.8. So, Viraj, Bhuvan said he will give. Would you give?
I do give. So the thing, as I told you, let's not put all tastes in one. High risk bees, definitely we should do. But let's say you have a 5 centimeter tumor and you're just giving taste, there's no risk factors. I'm
Okay.
not sure IO is adding anything there.
Okay, understood.
My bigger problem with the 5 centimeter HCC is that in my center, end up doing more tear than taste for them, and
Yeah.
I don't have a data there.
All same,
So I
no?
think that's my
Yeah.
problem. That's my problem that, whenever you have a large central tumor and you do a tear, and then you have to convince your interventional radiologist that why am I doing it? And they say that my tear is almost as curative as your DB or a LEAP 012 would be. So
Correct.
I think that's my challenge.
The problem with tear is, of course, there's been no head-to-head versus other things, and the only head-to-heads are versus TACE one study, and they have done low-dose tear versus high-dose tear and said high-dose is better. So those are the two studies which the tear people keep trumpeting, but that's how it is. This is the IM Brave, and here they had resection or ablation. And again, initially the PFS was there, but long-term when you saw, this was interesting. There's an updated efficacy data, and even the RFS is not met. OS also, the stratified hazard ratio is 1.26. So again, I don't know if you can break it and say some groups will do better or not, but at least after this data, I am a little disappointed. So post-surgery, at least I have stopped doing Etizobev. Viraj, your thought on this?
Agreed. So this is exactly what I was saying. Not all localized disease needs IO. We need to know which bees should be selected to IO. That's all.
How about those more up to 7? More than up to 7?
More than 7,
we would start with IO anyways, right? Not often.
No. So if I resect a 4 centimeter and a 3 centimeter,
So
and
I don't put all more than 7 into same basket, right?
no. So I'm giving you. So we say that post resection 050, it was a negative trial. ESMO readout was not there, and then you have that retrospective data of up to 7 and more than up to 7. So are you basing your decision on that?
So I think Bhuvan, the decision should be based at baseline on whether you're going to do a taste or not.
Exactly.
You cannot say, look, I'm doing a bad taste, but then I will compensate by giving immuno. I think that's the point which Viraj is making and which is completely. If you're having a scenario where you can resect 4 and 3, that's possibly if they're confined to one lobe, there is no cirrhosis or very early cirrhosis. Resection, that is a different issue. So I think that those are the patients who would actually come into your IM Brave 050 where it doesn't help you. That's
the only thing I can speak, not having seen, normally don't see this type of patient. But point is, if I look at statistics, for Bhuvan, it is a no-go for irrespective because the hazards is 1.26. It is detrimental actually.
Correct.
And so it should be very, very, very skeptical to even offer it to anyone who falls into this criteria.
So again, we have given it earlier for a couple of patients, but then this updated data came and we kind of stopped completely.
So you cannot take back that drug.
Right. So last part was about cytokine-induced killer cell immunotherapy. I'm not going into details because none of us have done it. But very interestingly, they had this kind of cytokine killers which they gave to post-resection. And, look at the result here. 44 versus 30 months with a hazard ratio of 0.72 and 10-year overall survival is close to 74%. I mean, these are patients of HCC where I hardly ever see them post-resection. So, 74% OS rate at 9 years is kind of very amazing for me. So this is something which is potentially going in the future. We were talking about this, about cytokines and immunotherapy. I think that's where we are going to head over the next 10 years. So that's my conclusion for today. And I think I will stop here. Any other discussion from the panelists or we'll close here? So if nothing else, then thank you, everyone. Thanks for joining in. I will request Dr. Shyam Agarwal to just give a closing statement for today, and then there'll be one more session at the end of it, which will be a 10-minute session. So Dr. Shyam, over to you.
Sir, we can't hear you. Can you, sir? So your voice is not clear, sir.
Am I audible now? Absolutely. Please, sir.
So thank you, Vamshi, for this opportunity. I think this was a marathon session amongst you all experts on GI cancers, focusing on, esophageogastric, BTC and HCC, trying to cover a lot of new things and the areas which are being debated. So just a few comments in a few minutes. I think the esophageal cancers you covered, immunotherapy to be added in the first line along with CTRT was not acceptable. So I think the way to go to is still with CTRT preoperative and then operate in a tumor which is more than 3 centimeters. As regards the intraperitoneal chemo, I think you need to be very selective for surgery in patients who achieve a CR after chemo, whether it is intraperitoneal or intravenous. I think there were a few discussion points on HER2 positive tumors, where I think we need to go to TDXD after the failure of trastuzumab. So those two abstracts were perhaps not, well taken. Regarding BTC, I think the current trend is towards doing NGS upfront to identify some of these mutations focused on FGFR or HER2/neu or BRAF and so on. And the cellular therapy part is interesting because in Mumbai, I think Vijay is beginning to offer CAR T cell in a variety of tumors. So you be in touch with him because he's talking about T cell receptor therapy for P53 or KRAS. So I think if somebody can afford a huge amount of money, and I think he can do those tests with the immunohistochemistry. So I think some of these patients with pancreas and biliary who are well preserved, who can afford a ton of money, can be offered, CAR T cells in Mumbai through Vijay Patil and his team. A word about ctDNA monitoring. I think it's true for lung cancer and maybe for colon cancer, which I think we'll be discussing tomorrow. But I think the future lies in deep sequencing so as to monitor the VAF as it falls, in patients who are receiving either chemo or targeted drugs. So I think we are far away from there, but maybe not very far, depending upon our ability to detect minimal residual disease. But I think for BTCs, once we have these targeted drugs, we are going to be, focusing on MRD through ctDNA. Currently, maybe it's not the way to go, but I think it's not far to my mind. In the next 5 years, we'll hear. So I think HCC, you discussed it very nice, threadbare role of IO and VEGF versus IO. And intermediate, yes, of course, the Emerald and the LEAP and the third study, does not have the approval from NCCN, but I do hear that you guys are offering it to your patients for patients with the intermediate stage. So I think it's not nihilistic. I think there are a lot of takeaways, new trends which are emerging from targeted drugs, from cellular therapy, from immunotherapy, from combinations. So I think although these diseases do remain difficult to treat, but I think we are making significant progress. So I think with this, I'll stop here and thank you again for inviting me for the comments.
Thank you, sir. So it's been a long day, like sir said. We have had 3 sessions, but only one little bit left behind. I would request we would be doing a sponsored session by Advanced Medlinks on ctDNA. Can you share the slides, please, Tarun? If you have this, can you share it, or do you want me to share?
Sorry, we are sharing, sir. We are sharing.
Oh, okay, just right. So this is on personalized ctDNA for MRD assessment, and this is actually, again, one of the things which are happening. So next slide, please. So the way ctDNA is being tested is right now for looking at patients who are either having an early relapse. You're also trying to find risk features, and it also acts because most of the present things that we have, like imaging or biomarkers, have low sensitivity and specificity. Next slide. So using ctDNA for MRD assessment, the idea is that you would be using it in two ways. One, you can look for molecular residual disease. And number two, it can be a real-time biomarker. Because the idea is that you can keep doing it on multiple occasions and try to see if the tumor is going to increase or not. So it can act as a dynamic marker as well. Next slide. So you can use it either before surgery, you can use it post-surgery to decide if you need additional therapy. You can look at it for early recurrence, or you could look at for treatment, whether it is working or not. So theoretically, all these places we can be using this ctDNA. Next slide. So this, what we are discussing today is the Signatera, which is a tumor-informed approach. Now, again, the idea is you do a tissue upfront, do a comprehensive genomic profile, create a profile for that tumor, and then look for it. That's the idea of a tumor-informed profile, and it makes sense logically. Next slide. So Signatera can use ctDNA dynamics over time. Again, the idea is it is not just one time assay. You have to keep doing it over multiple times. Next slide. So where all has ctDNA worked? Where all is Signatera approved? You have colon, wherein it gives you a median lead time of close to 8 months. It also says that patients after surgery, those who are ctDNA positive, have a much earlier response. It has shown similar results in breast. It is showing results in lung as well, though that's not somewhere where we are right now doing in every case because the sensitivity is not as high as the other places. It's also being used in bladder cancers. Next slide. So looking at colorectal specifically, Dr. Sham was talking about this, that colorectal is where it is doing. Next slide. So we have data now on Signatera in 2 or 3 different trials. Next slide, please. Next slide. So this was the Circulate Japan study. What they essentially looked at is stage 1 to 4, R0, R1 resection. They had 2 groups. So they divided into post-op ctDNA negative or positive. The positive patients went into the Altair study, which was an escalation study. The Vega study was a de-escalation study. So essentially, they looked at those patients who were negative ctDNA, observation versus Kpox, and whether it was non-inferior or not. The Altair tried to increase the dosage by adding trifluridine triparacetyl. So next slide. Now, this showed that those patients who remained MRD positive, that is in high risk stage 2 and stage 3, if they were ctDNA positive, they derived more benefit from adjuvant chemotherapy. Overall, however, these patients did not do as well as those patients who were ctDNA negative. Next slide. And that is the theme of all the ctDNAs that we have been evaluating. If you are ctDNA positive, you would derive benefit by taking chemotherapy. If you are ctDNA negative, you would do much better than those patients who are ctDNA positive. This is the general kind of approach that we see. Now, the Galaxy study has shown that if you give chemotherapy in ctDNA positive, you benefit. Next slide. Whereas those patients who are MRD negative actually did not get any benefit from adjuvant chemotherapy. So this is specifically shown in high-risk stage 2 and stage 3. And this possibly is the basis of what we are doing nowadays. So if you have a ctDNA negative post-op, you could possibly avoid chemotherapy. If you are positive, you would still get chemo, though you would not do as well as those who are ctDNA negative. That's the take-home message. Next slide. Next slide. So you also found that the other cohorts have shown similar result. If ctDNA negative, you do well. If ctDNA positive, you do badly. Again, this is a question which is often asked. If you have early stage and you have ctDNA positive, would further chemo help? It looks like it will help, but is it based on a randomized phase 3 study? And the answer is, as of now, not yet. You don't have a study to say this, but the data seems overall something that will support the statement, and really ethically you won't be able to do that. You can't tell a patient is ctDNA positive and then randomize for no chemo versus chemo. So I think that's where the problem lies. Next slide. Again, to say there was another study called the Predator that showed a similar thing. Next slide. Next slide. From ASCO GI 2024, again showing that those who had patient ctDNA positive would do badly. And you look at these studies, all of them say the same thing. If you are ctDNA positive, you will do badly. Next slide. Again, if you had a ctDNA positive which then cleared subsequently, you would do better than those patients who did not have clearance. So ctDNA can help detect who will do well later on as well. Next slide. And this is again showing similar things. Next slide. So this was the bespoke which came this year. Again, looking at multiple testing over time that they did once in every 3 months ctDNA. Again, can this be done for every patient? The answer is obviously not. You won't be able to do for every patient, but those who can afford, those who are willing, this does help you. Next slide. So bespoke again showed that there was benefit observed from adjuvant chemotherapy in MRD positive, not there in MRD negative patients. The hazard ratio is actually as good as 3, wherein if patients who got adjuvant chemotherapy did much better than those who were on observation. Next slide. Next slide. Again, ctDNA is predictive for DFS in stage 2 and 3. And this is in ASCO GI 24, ESMO, and again the bespoke 2024. All over, the Signatera has a prognostic power to detect patients who will do badly. Next slide. Next slide. Do we have any MRD guided trials? And that is what is going on. The Circulate. Now, the Circulate was the sister study of Circulate Japan. And they looked at those patients who were ctDNA positive, randomized to FOLFIRINOX versus FOLFOX. Those who were ctDNA negative were either on surveillance or FOLFOX or CAPOX. Next slide. This is the Vega and the Altair, which I had already discussed earlier. That was the de-escalation escalation. So overall, there are some studies which will be done, and we all have the similar cases. So a 69-year-old male with a T3 right-sided who has KRAS mutation, PNI plus negative margin 35 lymph nodes. This is a patient where would you give or not give? Well, personally would actually hesitate to give. Only the PNI would kind of push you to give adjuvant therapy. How would you monitor? Typically, we'll do only CA and CT scans. Longitudinally monitoring, you do have a positive Signatera, at which time you would not act, but you would wait and see. Now, in this patient, 3 months later, you found a liver lesion and he underwent an RFA. So you could argue that by doing 3 monthly CTs, you would have picked this up anyways. The counter argument is once you are crossing 1 year, as per present data, you will not do a scan unless the CA is going up. So it can help in some cases. Next slide. So overall, by looking at ctDNA, you will know the patients who do badly. You can detect those patients who will do well. So next slide. So that was the study. And thank you everyone for logging in till now over a long day. And I hope everyone joins tomorrow as well. So good night, everyone.
So thank you so much, Dr. Vamshi sir and everyone for a great discussion today. And we log in tomorrow again at the same time by 7 p.m. Till then, with the help of my colleagues, Aram, Abhimanyu, and the support team, thank you so much. Good night. Stay safe. And we join again. So Dr. Vamshi sir,